السلام عليكم.
عليكم السلام ورحمة الله.
عليكم السلام ورحمة الله.
Good evening, sir.
عليكم السلام ورحمة الله وبركاته.
وعليكم السلام ورحمة الله.
Okay, guys, inshallah, today we'll continue for examination, injured patient. In the new curriculum, they said injured patient, and it's a good point. Most likely they will ask about a joint examination, but at any time they can ask you about system examination. So the Royal Colleges, they are not doing the exam according to the blueprint. They can change at any time. They can change the mode of exam at any time. They can say the exam after, for example, after 1 week, it will be 14 stage, it will be 16 stage, it will be 18 stage. You cannot say anything, okay? So anyway, the most likely they will say injured patient, they are talking about joints, but we will be ready for joint or system examination, okay? So here regarding system examination, maxillofacial examination, eye examination, ear examination, thyroid examination, cranial nerve examination, respiratory examination, cardiovascular examination, abdomen examination, peripheral vascular examination, upper or lower neurology examination. So joint examination, the most important, we are talking about neck examination. Maybe the patient has trauma, so they will test your skills in Canadian spine and also examination for the neck. Back examination, the most important for them, is it sciatica or coda equina syndrome? Okay, so the most important to rule out coda equina syndrome from history in the start. History here in examination, not more than 20 seconds. Don't waste time in history in any examination. Even they ask you to take brief history, no need to waste the time. The most important question. So here regarding back examination, so you ask about urine problem. Do you have any urine problem like retention or incontinence? Do you have bowel problem like constipation or incontinence? Do you have problem in sex drive? Okay, these are the most important in history. After that, regarding the examination, don't ask anything related to examination. For example, don't say, do you have any weakness or numbness? Because you can get from examination. It's not logic to ask anything related to examination. It will not be counted for you, and it will be against you, because you are in examination. If you ask the patient like that, it means you don't understand the situation. Okay, so in the end of examination, you can check sensory and the motor, or at least sensory, So check the patient. I know some videos like GK videos, they did not mention or they did not do examination for motor and sensory regarding back examination, but it's required. Some people in this exam, they ask them to do sensory and the motor examination in the lower legs. So if the patient has sensory loss in bilateral, what is the diagnosis, guys?
Diabetic neuropathy or
coda equina.
Coda equina.
coda equina.
We are talking about back examination, guys. We said sciatica and coda equina. Did I mention here diabetic neuropathy? I did not mention. Okay,
Ah,
so
yes, sir.
take care, be alert always. Okay, I said maybe sciatica, maybe coda equina. Okay, here if the patient has trauma, also think about fracture in the back, right? Think about fracture. If the patient doesn't have any history of trauma, so maybe malignancy. Okay, so anyway, it's not our issue here. This is examination. It's not about the past medical history. Okay, if you will ask the patient more details, it will waste the time. Like, do you have any past medical disease? If they said, yes, I have prostate cancer or lung cancer or, so it will be a spinal metastasis. That's why the patient has a back problem, okay? But anyway, it will be unlikely to do that. Shoulder examination, it's one of the most important examination. So you can expect maybe the problem in acromioclavicular joint, sprain or pathology, maybe impingement. Impingement here, it's pain on movement, but the patient can move. Pain on movement. Tear, the patient cannot move, so it's a tear. Okay, or weakness. The patient doesn't have pain, but he has weakness or paralysis. It's called a tear. If the patient has weakness, it's a partial or complete tear, guys.
Partial.
Partial. Partial. Partial. If he cannot move at all, it means a paralysis. It means complete tear. Okay. Can you imagine what is responsible for the movement? The tendon or the muscle. Okay. So if there is partial tear, the patient can move, but not complete. Okay. It will be incomplete. If the patient cannot move at all, so it's a complete tear. Okay. If the patient can move completely without weakness, but he has pain, what is called?
Impingement.
Impingement.
Okay, I think it's clear now. Tendonitis here, the patient has only tenderness. Okay, once you touch in palpation and he has severe pain, how you know he has severe pain and tenderness, guys?
Look
On
to
on
the
passive
face,
movement. Pain on passive movements.
facial expression.
Facial expression.
Facial
By
expression.
The examiner is checking your eyes. The examiner is checking your eyes. If you look at the eyes of the patient, he understands now that you are doing palpation correctly. Okay. If you are not checking his eyes, it's not counted for you. Okay. So I want you to be professional. I want you to verbalize everything to the examiner. So after you finish look, and you are now in feeling, palpation, so verbalize to the examiner. Through the patient, I will feel your shoulders, and I will look at the eyes of the patient. So now you are verbalizing to the examiner. I will look at the eyes of the patient for tenderness. Okay, so sometimes the examiner is behind you. He cannot see your eyes. Sometimes he is behind the patient. He cannot see your eyes. So you have to verbalize like that. Elbow examination, it's not common. It's not appearing in the exam, but you have to be familiar with that. Yes. Hand examination, very common, especially traumatic, because they said injured patient. So it can be non-traumatic. It will be rheumatoid arthritis, maybe old patient, and with history of any inflammatory disease. And it can be trauma, cut in middle finger. It will be flexor digitorum superficialis. So be ready for that. It's very common. And here in hand examination, the most important to understand the problem in nerve, in tendon, in bone, and so on. Hip examination, it will be examination for both sides to understand fracture frames. Sometimes it's bilateral fracture, so it's a semi fracture, and this one is unstable. Knee examination, here it can be fibula head fracture. It can be patellar dislocation or subluxation. It can be meniscal tear. It can be any tendon rupture. Okay, so be familiar with it. Ankle and foot examination, it's not common in the exam, not appearing in the exam. You have to be ready for that? Yes. Okay, so you have 6 stations. We will practice only today 6 stations. Okay, so we can practice the station more than one time. Okay, we will start by Dr. Abdul Latif, after that Dr. Aziz, after that Dr. Ahmed Al-Amin, Dr. Tariq, Dr. Raji, Dr. Osman, Dr. Abdullah Malik. Okay.
Yes, Doctor.
And Dr. Ahmed Al-Samad, Dr. Mazen. Anyone who is happy to practice, you can raise your hand at any time. Okay. Here regarding,
One question.
yes.
Yes, just because I'm repeating, so I want to share my past experience and also for knowledge. And because last examination in November, there were 4 examination stations. One was hand with tendon cut for flexor digitorum profundus, which went well for me. But the other 2 stations, one was back examination. As mentioned outside in the scenario, it was an old male patient with complaint of hip pain. And when I went inside the station and asked brief history, he complained of back pain. Then it's become confusing that scenario is hip pain, but the complaint is back pain. And then there is history of trauma. He tripped from stairs. Then started with only, with general inspection and by checking his gait and Trendelenburg test and bring him to the couch.
Ask
and,
the examiner clearly. Ask the examiner clearly. If you find something like that, you have to confirm with the examiner. No worries. You can ask the pie chart is hip examination and the patient is complaining of back. Okay. Yeah, you have to clear.
And, this should be. That's why. And if I can confirm that is better, then we can proceed on the right track. That the way the examination is for the back or for the
it's
hip.
your right. It's your right to put your feet on the right track.
Yes, exactly. And the other station also the same, an old lady, and outside in the scenario.
But you know, sorry to interrupt you. Sorry to interrupt you. The most important is the pie chart.
Yes, exactly. Yes, you are telling again to check pie chart and don't be scripted. Yes, you are right.
Yeah, sometimes the actor is not professional. So you have to follow the pie chart. The mistake will be in the pie chart or from the patient, the actor.
I cannot say because I think similar.
From the actor, I will believe the pie chart. I will believe the pie chart, not the actor. I'm asking you direct question. You will believe the pie chart or the actor?
Pie chart, yes.
Pie chart. Okay, so follow the pie chart always.
Dr. Hani, in such a case, can we ask the actor to point exactly where is the pain, for example? And if we see that it is different from the pie chart, we speak to examiner that it is different?
I prefer to clarify from the examiner.
Okay.
No worries. You can ask the examiner, I want to clarify the pie chart is hip examination and the patient is complaining of back. Is that hip examination? No worries. Okay, you can confirm. The examiner is there to help you and to support you. Okay, so here I will give just pie chart. This station we will not practice today only for joint, not for system. Tomorrow it will be for system examination. So here, if you find the pie chart, as we said before, number 1, the pie chart, number 2, the task, number 3, the station. So the pie chart here, examination, clinical reasoning, and communication. So what is your role here, guys?
Examination.
Examination. Okay. Another, the same scenario, another pie chart. Okay. Here, examination, clinical reasoning, and history taking. So what is your role here?
Examination and short history.
Yes, so examination, and you will take only very brief history regarding what happened. Okay, can you tell me more about that? So she will tell you everything. Okay, and if you need any specific information, you can ask here, but don't waste the time. Maximum 20 seconds in history. The same scenario, examination, clinical reasoning, and the teaching skills. So what is your role here?
Examination and so teaching.
You'll just in the beginning do the introduction for teaching, like anything that you wish
very
to learn,
brief.
and then you
follow. Yeah, don't follow the general approach of teaching, because the general approach of teaching and the introduction may be more than 1 minute. Okay, so I believe you have, after introduction, I'm Dr. Ahmed. I'm the most senior here. I'm the ED consultant. I believe you have one patient with face injury. Is that right? Yeah. So I will examine the patient, and please follow me and listen to me. At any time you can ask me. Done. Don't waste the time. It's not teaching like ECG or nerve block. Clear, guys? No need to go deep in general approach of teaching. Okay?
Honey, just question.
Yeah.
In case of maxillofacial trauma, do I need to ask about, do I need to check the eye for visual color and?
Just a verbalization.
Okay, okay.
Even you can mention in the end of the session if you have time.
Okay.
You can say, to complete my examination, I will do complete eye examination, complete ear examination. Did you get my point?
Okay, okay.
Yeah, in the end, if you feel you still have time, you can use this time.
Okay.
Okay. So we will start today for joint examination, injured patient, as the Royal College said in their new curriculum. So Dr. Abdul Latif, you have 30 seconds to prepare yourself.
Patient has claudication.
Yeah.
So I don't know, but I'm confusing. Does it for limb ischemia, maybe injury or?
Claudication here, it means you are talking about peripheral vascular examination to see if the patient has DVT or limb ischemia, to see if the patient has artery or vein problem.
Okay, okay.
So you will examine all vascular examination in the body.
Okay.
So
Okay.
start by lower limb,
Okay.
after that the upper limb.
Sorry, but because you said the injured patient, that is why I'm thinking. That's okay. It's okay. That's fine.
Yeah, yeah. You can start.
Good morning. My name is Dr. Abdul Latif Ali, the registrar. May I know your name and your age, please?
Yeah, Karan, I'm 29 years.
Nice to meet you, Crown. Crown, I've been asked to take some data from you and examine you. Is that okay with you?
Yeah.
Anyone attend with you?
No.
Would you mind if a nurse attend with us?
Okay.
So, Crown, meanwhile, do you have any pain? So I'll give you painkiller.
The nurse gave me painkiller.
Okay. Okay. So, Crown, my examination will include that I'm gonna look and feel and also move, and I might do some special tests. Is that okay with you?
Yeah.
Okay, so please can you lie here in the table in 45 degree, and also I want both of your lower limb and upper limb to be clear, and you can cover the area of the pelvic.
Okay.
Okay, so first of all, I'm gonna start by inspection of the lower limb. So I'm gonna look for any change in the color, any deformity, any wasting, any
Okay.
any change in the color, any swelling.
There is wasting in the right leg.
Okay, everything in the right leg. So then I'm gonna check the temperature by the dorsum of my hand, both of leg. Is there any coldness of the right leg?
Yeah, the right leg is cold.
Okay, then I'm gonna
And in looking, it's bolor.
okay. So then I'm gonna do deep palpation. I'm gonna palpate both the joint and look to the patient eye. Is there any feeling of tenderness or anything?
No.
And at the same time, I'm looking for if there is any ulcer, any loss of tooth, any. Okay, then I'm gonna do passive movement of the both leg, for muscle tone, and then I'm gonna check for the pulse. I will start by popliteal pulse. I will start by femoral pulse first. I will start by assess the femoral pulse. Then I will do femoral pro. Then I'm go to the popliteal area, and I will assess for popliteal pulse, and I will do popliteal pro. Then I will check the posterior tibial artery behind the median malleolus, and also I'll check for the tibialis pedis, and I will check is it palpable bilaterally. Then I'm gonna
in the right side. In the right side, it's weak pulse.
Okay. So I'm gonna go back to ask the patient to stand his both hand, and I will check the hand for any palm, any palmar erythema, any sweating, anything, and also I will ask the patient to keep his hand to the palm down to check for any tear staining, any translasma, and then I will start by checking the pulse, radial pulse. I check bilaterally for volume, synchronicity, and the rate, and then I will go for the brachial pulse, and I will also check the brachial pulse, and I will check the patient blood pressure down and up there, then down standing and sitting. Then I'm going to check for the carotid fluid first by the pail of the stethoscope. Then I will check for parotid. Then I will look to the patient for eye, for any translasma, any bell, and then I will open the patient mouth, ask him to open his mouth to see any pair. Then I will look to the patient abdomen for any abdominal pulsation, any mass, any pulsatile mass. Then I will palpate for the aorta in the abdomen, just 2 centimeters above the umbilical, and then I will check for the bruise 2 centimeters above the umbilical for abdominal aorta. Then I will check for the renal artery bilaterally, and then I will go to femoral again, and I will check for radiofemoral delay. is there any familiar delay? No, then I will go back to check sensation of the lower limb. I will start by the toes. I will check bilaterally and I will go up gradually. Is there any loss of sensation? Then I will ask the patient that I'm going to do
Thank you,
special
Dr.
test.
Abdulatif. Your time done. Okay. What do you think, Dr. Abdulatif?
Do I have some 3 minutes or 3 seconds? I will continue just for.
Okay, you can continue for 30 seconds.
Then I will do a special test, which is I'm asking the patient. Sorry for this question. Do you smoke, please?
No.
Okay. I'm gonna do a burger test. I will put the patient raise both of the patient leg up for for 2 minutes, and we'll see if the arm change to belt. Then I will ask the patient to suspend his leg besides the bed, and I will see if it changed. So most probably it might be changed. That means burger test is positive. Then I will talk to the patient that after I do the examination, according to the data I take from you, you have right limb ischemia. It's possible. You have problem with the blood supply to your right leg. The blood to the right muscle to the leg of your right muscle is insufficient. So I'm gonna do general physical examination, and also do a blood test. I will check, including your profile, blood clotting profile, and also I might need to do a ankle brachial index, and then we might need to do some radiology to the lower limb to see exactly where is the obstruction of your blood supply. So of the blood. So I might refer you to the plastic surgeon.
Okay, thank you, Dr. Abdulatif. What do you think?
I don't know. I think I didn't do well.
Okay, regarding the time management, did you control the time?
I think yeah, I take long time.
Yeah, it will be with practice. It will be good with practice. Okay. Anyway, we are practicing within 6 minutes. I think with more practice, it will be easier. But here, I want to listen from you, and I want to listen from other people as well.
So I need to ask the patient first regarding the history. And also I'm gonna ask the patient for if he has, for example, chest pain or heart racing or this question. Or also I'm gonna ask him about his past medical disease and if he take any medication.
How to save time? You can ask him, do you have any other symptoms apart from leg pain? If he said no, done, right?
Okay.
Yeah. If he said yes, I have heart racing, chest pain, anything, he will tell you. If he said no, it means he doesn't have, right? Okay. So you can concise this one. Good point. Okay. What else, guys? Anyone want to add anything to help each other?
Yes, Dr. Hani, please. Assalamu alaikum.
Yeah, alaikum salam.
Dr. Hani, about the ample history, no more we are asking about?
No need to waste the time. No need. Okay. But here, regarding the performance of Dr. Abdulatif, I want any comment to help each other, please.
To help, just I suggest that to memorize the OT para and put in our mind that some sections of OT para we don't need to ask about. So
we are here in examination now.
You said, yes,
we are in
as you said, okay, as you said, by practice, we will memorize fastly in part of second. That this we should ask, and this we should not ask It would be brief like this. I'm talking about the history now.
No need, no need. If they did not mention, if they did not mention anything clearly regarding the history, no need to ask about history at all. Okay. So examination
So
will be
we can jump directly to examination.
yes. So how can I help you? I have a leg pain. I'm sorry to hear that. Are you comfortable now? Do you have any pain? I will offer painkiller, whatever. So finish this part. After that, you can ask the patient regarding just when did that start, because it's important. You cannot get from examination. Okay, so it's 1 month or any trauma. You have to ask about any trauma. Okay, so it's very, very important to ask about this point. When did that happen? And any trauma, maybe it's a trauma. Okay, if yes, when the trauma. Okay, so these are very important questions. What else, guys?
Turhan, I think also I need to first wash my hand and wear PPE because it's examination.
Okay, what else?
I think that Dr. Latif did well, but maybe he's not familiar 100% with the approach because he expected the injury station. This is a vascular examination station. So I think that he should start from
This
above,
what
from the
happened.
upper limb,
This what
go
happened
to
in the
upper.
Royal College. The Royal College, they can surprise you. Okay, you can find this is the station the same way. Okay, what else?
So he have to go from the upper limb, start radial, brachial, cervical.
I prefer to start by lower limb. Why? Because the most important is lower limb. I am worried maybe you will waste the time and you will not reach the lower limb. And here you have two stages: upper limb vascular and the lower limb vascular. Upper limb vascular, it means we are talking about carotid from the neck to the radial. And the lower limb, it means we are talking from the aorta, from aorta to femoral to popliteal to tibial, posterior tibial, and the dorsalis pedis, right? So I am worried maybe you will get enough time to examine all. So start by lower.
Dr. Hani?
Yeah.
I think so. Yes, you are right, because the main important is the lower limb, and we have to ask for in one limb or both limbs when it
Yeah,
started
sure.
abdominal and abdominal he has any pain. So we have to, if bilateral, we have to go for the, keep in mind abdominal aortic aneurysm. If one side maybe there is stiffness or the back stiffness in the cervical spine, there is a compression or like this. So we have to be systematic only lower limb. If you have a time, you can go up. Either you cannot complete whole of the like this, I think so.
No,
you
you
right,
can finish. You can finish lower and upper vascular examination. Okay, but here my point: start by lower, because some people they are not very fast. This is my point. Okay, but you have to examine all. If you examine only lower limb, maximum 6 marks, or maximum 7 marks.
Okay.
Okay, without upper.
Do an examination. It's not very clear here. What type of examination needed to be done? Is it like it's just do an examination? Will they mention the specific examination in the exam? In the exam, the actual
exam, they will mention do vascular examination. It will be very clear. But here I did not try to check his skills, Dr. Abdulatif's skills.
Sure. Okay.
In the exam, it will be very clear. It will be do vascular examination. Okay, but they will not mention lower or upper. If they mention lower, it will be lower. Okay. Okay, so I will give you my comment, Dr. Abdulatif. Did you feel, guys, that there is communication between Dr. Abdulatif and the actor?
Nope.
He's talking to the examiner only, right? Guys, please be active. I am not talking to myself.
Dr. Hani, because when you pause, I think you want me to continue, so that is why I'm continuing. I just ask you question. When you are not replying, I'm continuing.
What I need from you, I want you to verbalize to the examiner and communicate with the patient. Okay. For example, here you talk to the actor in the start, and communication with the actor, and you did very well. Here, it's up to you if you want to start by upper part or lower part. It's up to you. Okay. Regarding the patient, I want you to communicate with the patient. For example, can you lie on the couch or in the bed? It's up to you. Okay, done. This communication with the patient. Okay, so I will look at both lower limbs for any blah 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 blah. Now I will feel your legs. I want you to talk to the patient, not to the examiner. I will feel your legs by my hands to check the temperature. Okay, I will feel for any tenderness, looking at the eyes of the patient. Okay, after that, you can go step by step. So, for example, in the upper part, I will check for a carotid pulse. Here, the patient doesn't know carotid pulse. Anything the patient doesn't know, you are verbalizing to the examiner. But if you ask him for hands, this communication, can you do your hands like that? Okay. Did you get my point, Dr. Abdulatif?
Yes, you are right.
I did not notice that you are talking to the patient. So talk to the patient and verbalize to the examiner. So for example, mouse, can you open your mouth? I will check for blah, 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 blah. Can you do your eyes like that? I will check for blah, 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 blah. Okay. So can you do your hand like that? I will check for blah, blah, blah. Can you do your hand like that? Okay. He will do. Okay. And here, communication, you are taking marks for communication because how we will communicate with the patient. You have marks here, right? If you will not do communication, it will affect your marks and it will affect the global marks from the exam. You have 5 marks, global marks from the examiner, other than the checklist. Clear?
Yes.
The examiner will give you 5 marks different than other candidates according to your performance, your attitude, your body language, your confidence, your communication. You are giving the patient a chance to do what you want. Okay, so this is very, very important. It's not about examination. I am sure all people will do the examination, but what is the difference between candidate and the candidate? Okay, so communication. Okay, anyone want to do this station again? I will change the diagnosis.
I can do, Dr. Rani. I am Aziz.
Okay, Dr. Aziz, you can start. I will give you 6 minutes. You can start.
I can start. Okay. I need to wash my hands and wear PPE. Good morning. I am Dr. Aziz, ED Register. May I know your name and age, please?
Yeah, I am Karan. I am 29 years.
Nice to meet you, Karan. I've been asked to take some data from you and examine you as well. Would it be okay with you?
Okay.
Are you comfortable now? Do you have any pain?
I'm okay. The nurse gave me painkiller.
You are comfortable at that time. How can I help you today?
Yeah, I have leg pain and this one for 1 month.
For 1 month. Okay, I am sorry to hear that. Now I need to check vital signs. Now, where is this pain? Right, left, or both?
Right leg.
Right leg. You said 1 month, right? Do you have any other symptoms like chest pain, heart racing? No other symptoms. Okay. What do you think regarding your symptoms? What's your concern and expectations from us?
I am worried because this pain increased 2 days back, and I am worried something serious in my hip.
That's valid concern, Mr. Karan. Now, I need to examine you, and this will involve me look, feel, and do some special tests. So I need to expose your lower body and upper body. Would it be okay with you?
Okay.
Okay. Now, I will, can you sit at the 45 degree? I will look your hands. Can you hold your hands like that? I will check your hands for pallor, cyanosis, or tar staining. and gangrene, for gangrene. Thank you. Now I will palpate your hands to check temperature, and after that capillary refill time. And after that, I will check for the radial pulse firstly for 1 minute, rate, rhythm, and volume. And normally I will check for bilateral, but for the purpose of the exam, I will check one side and check for radio-radial delay. And after that, I will check for brachial pulse and blood pressure from both arms, lying and standing. Thank you, Mr. Karan. After that, I will listen for the carotid breathe and palpate for the carotid pulse. And after that, I will check I'll inspect the abdomen firstly, look the abdomen for any pulsatile mass. And after that, I will palpate 2 centimeters above the umbilicus for aneurysma or anti-pulsatile, and breathe for the renal arteries and aortic arch. And after that, I will inspect the lower limbs. I will check for peripheral cyanosis, pallor, ulcers, gangrene, missing limbs, and muscle wasting and paralysis anteriorly, posteriorly, and ulcers for the ulcers between the toes and web space. And I will palpate for the temperature from distally and capillary refill time, and check tenderness by looking at the patient's eyes. And after that, I will check for the femoral pulse and listen for any breathe. And radiofemoral delay, I will check for it, and check for the popliteal pulse and for the breathe at the same site, and tibialis posterior pulse, posterior from the medial malleole, and dorsalis pedis bilaterally. Are you okay, Mr. Karan?
Yeah, thank you.
Thank you. And now I will check for the sensation. I will touch your sternum firstly. Can you feel that? Now I will check from the distally your legs. Can you feel that bilaterally?
Yeah.
So I will do some special tests too. This is called Berger
Okay.
test.
Regarding looking, the patient has redness in the right leg. Okay.
Mm-hmm.
Yeah, and the swelling in the right leg. Regarding redness and the swelling. Regarding feeling, it's hard to touch the right leg.
Mm-hmm. Okay, so I don't need to do Berger test for now, but I will measure the calves bilaterally if there is a difference between them. I will measure from the below the tuberosity tibias, below the 20 centimeter, and squeeze the calf, check for the pain response from the patient's eyes. Does there any response? Does there any
tenderness?
Tenderness, there is tenderness. Okay, Mr. Karan, I have finished my examination. Are you comfortable now?
Yeah.
Let me help you to redress. I think there is a blockage in your leg veins. So we call that deep vein thrombosis. So in order to confirm this diagnosis, we will observe you, take vital signs again, and do some ultrasound scan and take some blood tests, which is full blood count, kidney functions, liver functions, and coagulation profile. According to ultrasound.
Thank you. Mm-hmm. Okay, I will give you 20 seconds.
Okay. According to ultrasound, we will diagnose your situation, and I can consult you vascular surgeons. Did you understand what I told you, Mr. Karan?
Okay, so what is the treatment at the moment, doctor?
Yeah, that's a valid question. At the same time, we will give you blood thinning medicine, and if we confirm the diagnosis, you will continue to take blood thinning medicine again. Do you have any other
Okay.
question for me?
Thank you, Dr. Aziz. Thank you.
Thank you. I need to dispose my PPE and wash my hands.
Okay, thank you. Okay, what do you think, Dr. Aziz?
I have problem remembering the questions, so I need to do practice first.
Yeah, you did well. Regarding the memorization, you are talking about recalling the approach.
Yeah, yes.
It will be easy. This can be easy if you are practicing with yourself. If you will do the same approach with yourself and record for yourself, okay? It will be very easy, okay? And the practice with your colleagues as well. Anyway, here you have good communication with the patient, very good communication with the patient. You are not ignoring the patient. You are verbalizing to the examiner as well. And here you are not asking the examiner, even he will not answer you, but you have to ask the examiner. So in looking, so once you look to the patient, so you can ask the examiner in the meanwhile, I will look to both legs for what? Okay, for any redness, because redness it's looking for any swelling, because it's a difference between artery or vein. Here you are showing the examiner, you are searching for artery or vein. Okay.
Okay.
Yeah. So I will check for any redness, any pallor, any swelling, any wasting, right? Each one at the opposite: redness, pallor, swelling, wasting. I will check for here for any loss. Okay. After you finish looking, ask the examiner, and no need to look at the examiner, but at least move your head slightly to the examiner. He will understand. You can ask him any abnormality. Did you get my point, Dr. Aziz?
Yes, yes, Dr. Ani.
Yeah. So, for example, here, all colleagues here in this session, they are examiners. Okay, they will feel what you are doing. This will happen in the exam. Okay, so if I will say to the actor, can you lie on the couch 45 degree or lying, no worries. Okay, flat, no worries. So I will check, I will start by lower limb, or you can say I will start by upper body vessels. So the examiner will understand what you are doing. Did you get my point?
Yes, yes, Dr.
So I will start by lower body or lower part or lower body part for vessel examination. I will start by femoral. Okay, I will feel the femoral artery. I will listen for Berwi. After that, for popliteal. Normally, it's not palpable. After that, I will feel for Berwi, listen for Berwi. After that, blah, blah, blah. So before you do listen, you have to do look and feel, okay? So look here, I will look at both lower limbs for any swelling, for any wasting, for any redness, for any pallor, for hair, intact or loss. I will ask the examiner clearly, any abnormality, you will feel now I'm talking to you, okay? In abnormalities, the examiner will understand that you are talking to you, because it's not logic to ask the actor in abnormality, okay? So if there is abnormality, he will say. If he did not answer, don't waste the time. Don't wait for him to answer you. If he will answer, he will answer, okay? So in the end of the station, if the examiner did not answer you, you have to ask clearly any abnormality regarding blah, 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 blah. He should answer you, okay? So sometimes examiners, they are not concentrating in the station. Sometimes examiners are new. First time for them to take exam, okay? Or maybe second time, they are not professional examiners, okay? So maybe they will answer you, maybe not. Anyway, you did very well, Dr. Aziz. Here, just this point, okay, and the management plan. Regarding the management plan, just concise. So I'm sorry to tell you that you have blood clot in the vein in your right leg. We need to do complete examination, Doppler ultrasound scan for your vessels, and the medicine will give you blood thinning medication and refer you to vascular team. Done. So try to consult. Do some blood tests. Done. More than enough. If you still have time, you can do more details. So you mentioned already blood test and you still have time. So you can tell him blood test like blah, 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 blah. Like blood profile, complete full blood, full blood test. And you can mention to him anything you want. Clear, Dr. Aziz?
Yeah, clear, Dr.
Yeah. Okay, well done.
Thank you. Thank you.
Anyone want to add anything regarding this station to help each other, guys?
We have to tell any like a well score when you suspect DVT or not necessary.
In the end, if you still have time.
Okay. Okay.
Yeah. So you can tell him to complete my examination, I need to take more data from you to do a scoring system, and I need to examine your heart because this is peripheral vascular. Peripheral vascular, anything rather than the heart. So any vessel coming from the heart or going to the heart. Clear, Dr. Seridha?
Yes, yes, cardiovascular. Yes.
Yeah, cardiovascular, but here they said peripheral. The heart here is central, not peripheral. So don't examine the heart at all. If you examine the heart, it's against you, not even you have time. Okay, it means you don't understand the station. Okay, so peripheral here, it means any vessel coming from the heart. It means from, if you will start from upper or from lower, it's up to you. In the upper, so carotid, after that, brachial, axillary, not very important, brachial, after that radial, okay? Yeah. But start from peripheral. So start from radial, then brachial, then also Dr. Aziz and Dr. Abdul Latif, you forgot regarding collapsing pulse, right?
Yes, shoulder pain and collapsing pulse.
Yeah, do you have any shoulder pain? And in the tummy, so I will, can you expose your tummy? I will check for any pulsatile mass, so for aortic aneurysm. So here you have to verbalize to the examiner as well. And I will feel for the aorta, and great that you did verbalization for the site. So it will be midline and the renal artery. You will also listen to per week. Okay, so you did very well. The most important here, go for logic approach. Logic approach, it means upper limb or lower limb. It's not a big issue if you will control your time. But here, start by inspection. After that, palpation, feel. After that, auscultation. After
hello,
that,
sorry.
Yeah.
Sorry, Dr. Hani, sorry to interrupt. I'm Dr. Muhammad Ghaffar. So just regarding the actual thing what we do every day here in UK, say referral to a vascular surgeon after DVT, that's not what we do every day. So what we actually do, so once, say, for instance, I found a patient, so I would say, tell them, Mr. So-and-so, I'm suspecting it could be a blood clot. And whenever we suspect, we start the treatment. We assume it as though it was DVT, it was a clot, and I will give you a blood thinning medication and organize a Doppler scan of your legs. And if that proves positive, they will continue your treatment and your GP will follow afterwards. And if the Doppler didn't find any clot, they will discontinue the blood thinning medication I have prescribed. So what do we we have to do in the exam compared than the actual practice?
Excellent, the same, should be the same. Excellent, very excellent. I am always advising people in history taking or in examination, give the patient possibilities. Can you confirm without Doppler ultrasound?
Yeah, that's what we do. So we organize Doppler.
Yeah, I'm confirming your point. I'm agreeing with you. So I'm asking all people, can you confirm that the diagnosis from data only or from examination only? No. Okay.
No.
So you have, I am agreeing with you. You have to give the patient possibilities. I am suspecting, don't say the diagnosis is blah, blah, blah. Other word, you can say the most likely problem. So most likely problem until now not confirmed, right? Okay.
Yeah.
So we need to confirm the diagnosis by Doppler ultrasound, and I need to take more data from you. Okay. Yeah. So if confirm blah, 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 what we will do, blah, 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 blah. So give the patient possibilities. Okay.
Yeah, and also, sorry, I have never, I've been practicing for years here in the UK, but I've never referred a DVT to a vascular surgeon, and they would never accept just a usual DVT.
Yeah. So
it's only acute arterial limb occlusion is a vascular.
No, just the DVT.
Rest of them, it can be like a medical, or depends on how it
medical
comes.
team. Yeah. I agree with you. Medical team.
Yeah. So
if the patient has limb ischemia, you have to refer to vascular surgery.
Of course they will.
Yeah. Okay. So
but I can. Yeah. Sorry. So yeah, but that's beyond the scope of this examination. We can see both things coexisting. Two diagnoses in a single patient, but that's beyond. Yeah.
Unlikely.
Yeah, in the exam at least.
Yeah. At least unlikely in the exam. Of course, in the practice unlikely, but for the purpose of the exam, for sure, it's only one diagnosis.
Yeah. Perfect. Yeah. Thank you.
One thing, Dr. Hani, please. In the real exam, usually in the previous exams, the task is examine peripheral vascular system, or it's determined vascular for lower limb or upper limb.
As we said in the start, they will ask you do examination for peripheral vascular vessels. It will be peripheral vascular examination.
So they will not determine upper or lower limb.
No, they will not. If they determine upper or lower, it will be upper or lower only, as they mentioned.
I am asking usually in previous exams from your experience.
In previous exam, it was do peripheral examination only.
Okay. So we should do all upper and lower and abdomen.
Yes. People who did the lower only, they got 6 or 7. They did not get more than that. People who did the upper and the lower, 10 marks. Yeah.
Can I ask a question?
Yeah, please, guys. We're still in on the first station. Okay. Yeah, Dr. Panadol. Yeah.
What degree of neurological examination we can conduct? Because I've seen people ask about sensation. I've seen ask about power. I mean, any
no one ask about power here. Here only the sensation in the end. Distal sensation only.
Rohani, I think
it's like, please, I will finish this one only. Dr. Tamador, you will ask about distal sensation in both feet. Okay. It's like 2 or 3 seconds. Okay. Who else, guys?
Yeah, Dr. Hani, because yes, Dr. Tamador, because I'm asking about the. I just assess the power of the patient. Yes, this is by mistake. Yes.
Yeah. Regarding the power, it's a here vascular examination, not neurology. If neurology, they will mention do neurological exam for lower limb or do neurological exam for upper limb. It will be clear. The task will be clear. Okay. Next one, Dr. Ahmed Al-Amin.
Yes, Dr. Hani.
Yeah. Like this one, just the sensation in the distal only, it will take like 2 to 3 seconds only. Okay, Dr. Ahmed, you have 30 seconds to prepare yourself. You can start.
Okay, I'm going to wash my hand, put on my PPE. Hello, I'm Dr. Ahmed Al-Amin, ED Registrar. May I confirm your name and age, please?
Hariri, 32.
Nice to meet you, Mr. Hariri. Today I've been informed that you're having weakness and this disturbed sensation in your arm. Is this correct?
Yeah.
Oh, I'm so sorry to hear that. Are you comfortable now? Would you like me to give you any pain medications?
It's okay.
Okay, so Mr. Hariri, I have been asked to take a few data from you and also do an examination for you. Would that be okay?
Okay.
Okay, do you mind if a nurse attend with us or anyone else attend with us?
It's okay.
Okay, so let me first check your vital signs. Okay, Mr. Hariri, can you tell me, do you have any allergies, any medications you're taking?
No.
Any surgeries done before? Any medical problems?
No.
When was your last meal and your last drink?
4 hours.
Can you tell me briefly about what happened with you?
Yeah, I have weakness in right hand, and this happened 3 days ago.
Oh, I'm so sorry for that. So, Mr. Hariri, I would like to do an examination for the nerves of your arms and hands. Okay, this will involve me checking the sensation and also checking the movement in your hands and arms, plus also some special tests I'm going to do for you. Would that be okay with you?
Okay.
Okay, I need to prepare my equipment. I will need a neurotape. I need a cotton bud. I will need a tuning fork, a hammer. Mr. Hariri, first I'm going to do an inspection for Mr. Hariri. I'm going to look for any asymmetry, any deformity, any muscle wasting, any tremors, fasciculation, any abnormal movement, any mobility aids, any pills or medications. Mr. Hariri, can you please, I want you to walk to the end of the room and come back. Okay, thank you very much. Now I'm going to start by checking your arms. I need you to spread your arms in front of you. Yes, and I need you to turn your hands upward and close your eyes, please. Okay, I'm going to check for the presence of any pronator drift. Okay, now, Mr. Hariri, I would like to check the tone. Can you keep your arms floppy, please? Okay, I'm going to hold the hand, checking for the shoulder for adduction, abduction, flexion, extension of the shoulder, as well as the elbow, and then finally the rest. Okay, now, Mr. Hariri, I would like to check for the power of the muscles. For the purpose of the time, I'm going to check only on the right side. It should be done bilaterally. So first of all, can you do your arms like this? Okay, I'm going to check for the C5 check. Now, can you push against my hand downward? Okay, excellent. C6, 7 has been checked. Okay, I need you to to bend your elbows and put them in front of you like this. Don't let me pull them out. Okay, C5, 6 checked. Okay, and don't let me, and can you please push against my hand? Okay, C7 checked. I need you to straighten your arm. I need you to bring your hands backward. Okay, do not let me push them. C6 check. Okay, I need you to straighten, to push against my hands down. Yes, excellent. So C6, 7 check. I need you to bring your fingers together. Do not let me push your fingers down. So C7
Weakness here.
checked.
Weakness
there is a weakness here. Okay, that's the radial nerve and C7. Okay, I need you to display your finger out. Do not let me push them in. Okay, I need you to turn your hand up. Let your thumb point to the ceiling. Okay, do not let me push your thumb down. This C8T1 check. Okay, so Mr. Hariri, now I would like to check for the reflexes. Okay, now I'm going to check for the biceps reflex, putting 2 fingers on the biceps and hitting with the hammer. Biceps checked. Okay, now I'm going to check for the triceps reflex. Okay, triceps checked. I'm going to check for the brachioradialis reflex. Check. Now, Mr. Hariri, I would like to do checking for the sensation. Can you please feel this cotton wool on your breastbone? Okay. Now I'm going to touch whenever you say you feel it. Just say yes. Will that be okay with you? Okay. Now I'm going to touch for the shoulder for C5. Now I'm going to touch for the thinner eminence for C6. I'm going to touch for the base of the middle toe for C7. I'm going to touch for the hypothenor eminence for C8. Can you please turn your hand? I'm going to touch at the web, at the first web dorsally. Do you feel that? Okay. So I'm going to check at the axilla. For T1. Okay. Now I want to repeat this using the neurotip. Okay. Done. Then after that, I want to check for the sense of vibration. Can you please? Do you feel this tuning for buzzing in your chest?
The patient,
okay,
the patient cannot feel the middle finger.
Okay, so I need to do examination now for the position of the finger. Okay, I'm gonna hold the middle finger. This is down and this is up. Can you close your eyes? Can you feel this up and down? Okay, checked. So now, sir, I need to check for the coordination. Now I need you to keep one finger over your nose and touch my finger, okay, and do it forward and backward again. Thank you. We'll repeat this on the other side. Now I need to you to put one hand over the other and do as I'm doing quickly, okay, and on the other side. Okay, so the finding the patient cannot feel the vibration on the middle finger. He cannot also feel the what else with the movement. The patient cannot. There is weakness in dorsiflexion of the fingers. So, Mr. Hariri, according to the examination, it seems that you might be having a problem.
Thank you. Okay.
Thank you.
I'm the examiner. What is the problem? Is it upper or lower?
Actually, the patient cannot feel the vibration and.
What is the problem? Upper or lower?
It seems to be lower.
Okay, lower.
Because
so the problem is lower motor neuron lesion.
Yes.
It means outside the brain.
Yes.
Okay. So here is the problem. Is it median or ulnar, median, or radial nerve?
Radial nerve.
Okay. So what
sorry,
is your
Dr. Hani, I have some patients. Sorry, I have to go.
Okay.
Sorry,
okay.
I'm at work.
Okay.
Sorry.
Okay. So here, what about the comment, guys? What do you think regarding approach of Dr. Ahmed?
Excellent, I think. And when I think also, Dr. Hani, when you ask about lower or upper, I think it is it from the beginning when he do a pronatal drip, you can know if he is that.
Yeah. Okay. So here you have to verbalize to the examiner. I will do pronator test to know the problem is upper or lower. The examiner will understand that you are professional from the start. Okay. You are doing the tests and you understand why you are doing this test, but the examiner doesn't understand why you are doing this test. You are keeping secrets for yourself. So you have to show the examiner. Okay. Okay. Here in this station, the most important pronotor drift. So if positive, the problem upper motor neuron lesion, the problem in the brain. Okay. If negative, so the problem lower motor neuron lesion. Okay. So from the start inspection, I will check for any scars, wasting, involuntary movement, fasciculation, tremor. Okay. Also, you can add AD. So A for asymmetry and D for deformity. So I will check for asymmetry, deformity, scars, wasting, involuntary movement, fasciculation, and tremors. After that, you can ask the patient, can you do like that? Can you do like that? Can you do like that? Here you can check the tone. So flex your sorry, relax, and I will do for you. So you will shake hands up and down and left and right. After that, you can check the tone. After that, but talk to the patient as Dr. Ahmed did. Thank you. Just relax, I will do for you. Thank you. So this communication with the patient, okay? So here the power, can you do like that? He will do. Don't let me to push down. Don't let me to push up. And verbalize shoulder abduction, okay? Here, can you do like that? Don't let me to push down. Don't let me to push up. So down first, after that up. Down first, after that up. Okay, don't let me to push down. Don't let me to push up. So here we are checking which joint, guys.
The shoulder.
From your
Shoulder. So you have shoulder, you have elbow, you have wrist, you have fingers, right? So check one by one. Now support the joint you are examining. So the examiner will check which joint you are supporting, which joint you are examining. So if you want to examine the shoulder, support the shoulder by one hand, and the other hand will do up or down. Okay. So don't let me to push down. Don't let me to push up. Shoulder. Here we are examining which joint, guys, after the shoulder. Elbow. So shoulder, elbow, wrist, fingers. So you will support the elbow by one hand and the other hand do down, the other hand do up. Okay. So don't let me to push down. Don't let me to push up. It's very easy to communicate with the patient. Can you do like that? Don't let me to push down. Can you do like that? Don't let me to push up. This one, which joint, guys? Wrist. Okay. So wrist here, you will push down. Okay. No need to support because you will push the wrist down. So you have to support the forearm like that. Don't let me to push down. Don't let me to push up. Okay. Here you are examining what?
Fingers.
Finger. So you have to support the wrist. Why? Because if you will hold the forearm, the wrist will go down. You don't know the problem in the wrist or in the finger. So this one, if you will examine the finger, you have to support the wrist. So in abnormal, yeah,
Extensor muscles.
yeah. So here the most important, you are checking the fingers. Don't let me to push down and don't let me to push up. Here are the fingers. So can you display your fingers like that? Don't let me to push inside. Okay, this one also. So index and little finger. Okay, so index and the little finger for which nerve?
Ulnar nerve.
Median nerve.
Ulnar nerve.
Oh yes, ulnar nerve.
Ulnar nerve. So don't let me to push down. If the patient has abnormality, which nerve?
Radial nerve.
Radial nerve. Can you do your hand like that and your thumb up like that? He will do. Don't let me to push your thumb down. So if he has abnormality here, which nerve?
Median nerve.
Median nerve. So the same examination in any upper neurology, but according to the abnormality, here the patient will act as flexion. You will ask him, don't let me to push down. It will be weakness. Your finger will go down here. So it will be radial. Here you ask him to not let you push inside. it will be weakness. It means it's ulnar here and here. Okay, here it will be median. So the same examination, but according to the finding, you will diagnose. Here, don't waste time with the examiner. You can tell the examiner or tell the patient the problem in the median nerve, the problem in the ulnar nerve, the problem in the radial nerve. And it's if you will talk to the examiner, the problem is lower motor neuron lesion. So what is the management, guys?
First of all,
MRI?
Yeah. So if it is lower, then MRI of the cervical spine.
But the patient has no trauma, for example.
Even though there is impingement or there is a space decrease of the space between them, and there is some compression, maybe there any tumor or anything was there that is compressing, because of that is feeling weakness.
No conduction study.
Okay, so you will refer to neurology. Do you need anything now? Do you need anything from the patient? Do you need to do any further workup? The most important, refer. Okay, there is no trauma, no trauma. If there is trauma and you check he has neck pain or he has cervical, it's unlikely to be in this exam, in this station. Okay, so for the purpose of this station, just refer to neurology, right?
Yeah.
Okay. Here the most important, you diagnose him already and you have a suspected diagnosis for the neurology, so you can give him appointment for neurology. Okay. So after that, you will do, can you do like that for me? She will do or he will do. After that, can you feel that in the face? So can you feel that? Don't say, can you feel that on your shoulder? No. Just, can you feel that? If she said yes, it means that she feel. Can you feel that? And mention the name, C5. Can you feel that? C5. Can you feel that? C5. Can you feel that? T1. Can you feel that? T1. And always do the unaffected one. So the patient has problem in the right side. Which one you will start, guys? Right or left?
Left side.
Okay. So from the start, the patient has problem in the right side. So I will start by the left. Why? Because I will compare with the right. So can you feel that? Yes. Can you feel that? Yes. C5. Can you feel that? Yes. Can you feel that? Yes. T1. Can you feel that? Yes. Can you feel that? C6. Can you feel that? Yes. Can you feel that? No. The patient has abnormality in the radial nerve. One by one, guys. Don't waste the time to the end of the station. Verbalize to the examiner. Okay? The patient has abnormal sensation in C7 in the radial nerve, lower motor neuron lesion. Can you feel that? Yes. Can you feel that? Yes. C8 intact. So once you say C6, you can say to the examiner, C6 intact and median nerve intact. Can you feel that? Yes. Can you feel that? No. The patient has problem in C7, the median nerve not intact.
Dr. Hani, just a question, Dr. Hani.
Yeah.
When I was telling that turn the hand, I'm going to check the dorsum, because when you told me that the patient does not have extension of the fingers, I thought about the radial nerve. And when I said turn your hand to touch the web in the first web dorsally, you didn't comment. So I got confused about whether it is a radial nerve injury or not. And also about regarding the vibration, you told me that the vibration is not felt in the middle finger.
I did not comment about the vibration at all.
You didn't tell me when I was telling the vibration?
No. The most important for you, the motor and the sensory. Don't depend on the vibration. Okay. So, yeah.
Maybe I heard it incorrect. This is why I got confused at the end. What's the vibration?
Yeah.
Why vibration loss? Okay.
Yeah. Don't let me to push down. The patient has paralysis or weakness. Okay, here. So you can verbalize to the examiner, the patient has weakness and C7 not intact. Radial nerve not intact. Clear? Here, don't let me to push inside. Don't let me to push inside. Ulnar nerve intact. Clear, Dr. Ahmed? You have to verbalize like that.
Yes, doctor. Sorry, I was making the station while the nurse is knocking on me, patient.
Yeah.
I was a little bit confused when I was doing.
Don't let me to push your thumb down. You will find resistance in the exam. So verbalize to the examiner, median nerve is intact, okay? And so on. So anything intact, no need to comment on all. You have no time to comment on all. The most important in the hands. So C6, 8, 7, okay? So if you find something intact, comment intact. If you find something not intact, it's not intact. And
Dr. Hani, here regarding the management, is it like I'll keep you in observation room, do also examination of your cranial nerve and your lower limbs and call the neurologist for you? Or
don't waste the time. To complete my examination, I need to do complete examination, complete physical examination, and cranial nerves, and do vascular examination as well. Maybe the problem in vessel, right?
Yes.
Maybe decrease blood supply, and if confirm it's the diagnosis according to the station, so you can refer the patient to neurology, and you can complete your examination regarding reflexes. Here it's not important to do that. No need to do that. Okay, it's just the vibration and proprioception and this test as a routine. Okay, well done, Doctor.
Sorry, Dr. Hani. Sorry, can you repeat for me? I was not attentive. When difference between upper and lower motor neuron lesion, please.
Upper and lower?
Yeah, probably you said pronator test, isn't it?
Yeah. So here from the start, you can ask the patient to do, just verbalize. Can you do your hand like that and close your eyes? If the patient change the position of the hand, if the patient change to pronation, okay, it will be positive. Okay. Yeah. So you can verbalize to the examiner from the start. To check the problem if upper or lower motor neuron lesion. Or you can say if positive, it will be upper to concise the time. Okay.
Okay. Yeah. Thank
you. Yeah.
Turan, sorry for
this
last
one.
question.
This one no need, guys. This in shoulder. Okay. Yes.
Regarding the sensation for C7 exactly, do I need to assess the sensation through the palmar aspect of the finger or the dorsum aspect of the finger?
Dorsum.
Okay.
Dorsum. So here no need to say palmar or dorsal. The actor can give feedback to the examiner. Okay. So the examiner can ask the actor after you go. You have 1 minute between station and the station. In this 1 minute, the actor give feedback to the examiner. So if you touch this side and this side, the actor will give feedback to the examiner. You did the exam properly. Clear, guys?
Okay, thank you.
Yeah. Okay, next station. Dr. Tarek?
Yes.
You have 30 seconds.
Start.
Okay, you can start.
I will wash my hand and wear PPE. Hello, Mr. I'm Dr. Tariq, one of the senior doctor, and I have been asked that I have to examine your lower part of the body. Is it okay with you?
Yeah, doctor, I have weakness in my right feet.
Okay, I'm sorry to hear this one. Can you tell me how many, since how long you have this weakness?
Yeah, 3 days.
3 days. Is suddenly or this is gradually started?
Cannot remember.
Okay, so okay, and I will ask my sister as a chaperone. It's okay with you?
Okay.
Are you comfortable at this time? Need any painkiller? I will offer a
It's
painkiller.
okay. It's okay.
Do you have any allergy?
No.
Any past medical or surgical history?
No, no.
Are you taking any medicine at this time? Prescribed medicine or?
No, no.
Okay, for the examination of your lower limb, I will first of all I will expose your lower part of the body and to examine you. It's okay with you?
Okay.
Okay, and in between, if you feel that you are not comfortable, if you want to stop me, you can stop anytime. Is it okay?
Okay.
First of all, I will examine, I will look from the front that there is any wasting of the muscle, any deformity, any muscle twitching, or there is any weakness, or about the muscle bulk of the muscle bilaterally. Is it okay? And I saw that there's a, and I will go on the lateral side and I will see any deformity, any arch of the foot, and when patella as well as patellar, bilateral patella, that both are normal in position or not. This one, and I will see on the back side from the popliteal fossa, and I will see any swelling, any deformity at the popliteal fossa, or any swelling or the redness.
You mean I am sitting or I'm lying or I'm standing or what do you want?
Standing, standing.
Okay.
Because I will see. Is it okay? Do you feel, are you comfortable?
Yeah.
Okay. Now I will see that the Telindenberg. Can you walk for me?
Okay. I have foot drop.
Oh, I'm sorry. It's okay. And okay, you can lie down. I will see you now. I will palpate. Is it okay? And I will see the muscle grip of the quadriceps muscles as well as bilaterally. And now I will start to palpate. I will palpation, and I will see the movements. And first of all, can you flex your knee joint for me? Right side, from left side, first of all, because I will go from the normal side, and then I will go for the abnormal side. Is it okay?
Okay.
Okay, I will go for the movement of the leg, first of all. And I will see that, first of all, knee joint, is there any flexion and extension of the knee? And he's flexing bilaterally. I will see which side is weakness, if flexion is bilaterally equal or not. Then I will go for the medial rotation and lateral rotation of the hip joint and knee joint, as well as to examine the weak movement of the hip joint. Okay, and after that, I will do the extension, and I will do this hip. Now I will go for the hip joint. I will see the movement of the hip joint, all flexion, extension, lateral rotation, and medial rotation as well. Any weakness, any part of the body, any weakness during movement of the body, leg. Okay, I will go after that, palpate the dorsalis pedis artery, posterior tibial artery, and then I will go for the popliteal, and I will see the femoral as well as. All the pulse are intact.
Here, peripheral nervous system.
Okay. Now I will go. I will go for the sense. I will go for the sensation. I will see that I will start from the toe I will start from the hip joint and I will see that L2 and just below the hip joint and L3, I will touch, I will do the sensation. Okay, this is, I will take this pin or soft any cotton and I will ask him that please can you close the eyes for me. So I will check the sensation.
The patient cannot feel the lateral side of the foot and the lateral side of the leg.
Lateral side of the foot and lateral side. Okay. So
what movement you want to do for the patient?
I want to do the plantar flexion and dorsiflexion of the foot.
Yeah.
Bilateral I will check.
You mean against resistance?
Yes, against resistance. I will ask the patient, can you flex your foot up? So
there is problem in dorsiflexion.
In dorsiflexion. Okay.
Yeah.
And I will go for the sensation that I
Second. Thank you, Dr. Tariq. Thank you. Okay. I am the examiner. What is the diagnosis with you?
I might this foot drop because of common peroneal nerve, and maybe he has a fracture of the head of the fibula. So when I will palpate and examine the patella, so maybe I will feel the tenderness at that side, and I will ask the patient and attendant that I feel that there is some fibular fracture. So because of that, you have this foot drop. This is common peroneal nerve. I will put the back slab. And I will do X-ray for you, and I will call the orthopedic. Might be I will refer to you to orthopedic.
Okay, thank you, Dr. Tar. So here, this station, it's a nerve. We are talking about neurology. Okay, so neurology, as usual, after introduction, after everything. So neurology here, we are talking about power and the sensation, vibration, proprioception, and everything like that. Okay. So first of all, you can here طبعا maybe fracture of fibula. Okay. But anyway, if the patient doesn't have trauma or doesn't have back slab, so don't be scripted. Maybe the station is different. Don't be scripted, please. So here, first of all, you will ask the patient to walk. Okay.
Yeah.
You will the gait. From the gait, you will find foot drop. So verbalize that the patient has foot drop. Okay. To the examiner.
Yes.
Okay. And here you have to support him. Maybe at any time the patient will fall. So you can go with him. If the examiner can see you are supporting the patient, it means you are showing support. This marks for you. Don't ask the patient to walk and between you and the patient 4 meters. No. Okay. So go with him step by step. And after that, Romberg's test. So you will, if positive, it means loss of balance. And this is upper motor neuron lesion. Okay. Okay. So after that, you will check for the which one, this tone or sensation, Dr. Tariq?
Sensation.
Tone. Okay. Any movement, we are talking about motor. We are talking about, yeah. So you will do leg roll. Okay. After that, leg lift. So ask the patient to relax, and I will do movement for you. So this one you will move to left and right, leg roll.
Yes.
Left, verbalize to the examiner. Okay. Yeah. So leg roll. After you do the test, verbalize to the examiner. Leg left. Okay. After that, you can do to the patient ankle colonus. So you will support the leg from down by one hand. The other hand move the toes left, right. After that, dorsiflexion. Left, right. After that, dorsiflexion. Okay, suddenly. After you finish that, you will go for movement. So here, this one is tone. This one sorry, this one tone, and this one the power. So ask the patient, don't let me to push your leg down, don't let me to raise your leg, and here bend your knee, don't let me to push up, don't let me to push down. And this one you will do dorsiflexion, don't let me to push down, don't let me to push up, and the finger is the toe, don't let me to push up. Okay, so after you finish, the patient will have problem here, this sensation also. So can you feel that on the sternum or on the face? Close your eyes and let me know if you feel, say yes. Okay, so you will do on lumbar 2, L2, L3, L4, L5, S1, L5, L4, S2. So here he have problem in common peroneal nerve injury. So if the patient has whatever fracture, or maybe it's not trauma, okay, don't be scripted. So common peroneal nerve, we are talking about two nerves. Deep,
and
it means between the tibia and the fibula, deep, and the other one superficial peroneal nerve. If the patient has problem in both nerves, it means a common peroneal nerve problem. If the patient has only one nerve problem, so don't say common peroneal. If he has only problem in deep peroneal nerve, so you can say it's a deep peroneal nerve problem. If he has problem in superficial only, so you can say superficial peroneal nerve problem. How you know that? If the patient has a problem in sensation in the lateral side, so what is the problem, guys?
So this is superficial.
Superficial. If the patient cannot feel, can you feel that here? Yes. So compare the normal one with the abnormal one. Can you feel that in the lateral side? Yes. Can you feel that? No. Can you feel that? Yes. Can you feel that? No. So the problem where, guys?
Superficial
peroneal nerve. Okay, we will go for deep peroneal, the web space. Can you feel that here in the normal one? Yes. Can you feel that? No. So the problem where, guys?
Deep
peroneal. It means he has problem where?
Common peroneal nerve.
I think it's clear now. Okay. Yes. Okay. So once you go to the sensation, you will diagnose this one from the gait. The patient will do foot drop like that. Okay. So support the patient. Don't watch the patient 1 meter or 2 meters away of the patient. It's against you. So when you ask the patient to walk step by step beside the patient, okay, take care of the patient. And here, verbalize to the examiner, the patient has foot drop on walking. After that, once you reach a sensation, can you feel that? No. Can you feel that? Sorry, in the lateral side. Can you feel that? Yes. Can you feel that? No. Verbalize to the examiner, superficial peroneal nerve not intact. After that, check the web space. Can you feel that? Yes. Can you feel that? No. And the deep peroneal, verbalize to the examiner, the deep peroneal nerve is not intact in the right side. So he has problem in common peroneal nerve. Okay. So after that, the motor here, the patient will get problem where, guys, in dorsiflexion or plantar flexion?
Plantar flexion.
Bring up. Yeah. So here, regarding superficial peroneal, he has problem in foot eversion. Okay. So you can put your hand here, right hand here, and left hand here. Don't let me to push your feet. Okay. If he has problem in eversion, so problem in superficial peroneal. So this one intact, this one not intact. Here he can push you. Here he cannot push you. Okay, so foot eversion, what does it mean, guys?
Foot eversion, superficial.
Superficial pressure.
Yeah, don't let me to push down. So you will put your hand here down the feet and one hand here down the feet, and you can push up. Push up, it means it's a plantar flexion, the opposite. If you will put hand here and the hand here and you will push down, it means dorsiflexion because he will do dorsiflexion. The action the patient will do, this is the most important. Okay, so if the patient has problem in dorsiflexion, what does it mean?
Deep peroneal nerve injury.
Yeah, deep peroneal nerve. So remember that in walking he has foot drop. In sensation he has lateral sensory loss. It means superficial. He has deep peroneal here in web space loss. It means he has common peroneal. And in motor, he has foot eversion problem. He cannot do eversion. He cannot do dorsiflexion. It means you have to put your hand above the dorsum of the feet and push down. Which one will be intact, guys? The left side, and the right side will not be intact. So he has weakness here. This one you cannot push the feet down, but this one you can push the foot down. Okay. To extension, you have to put your hand on the big toe here and on the big toe here on the dorsum side and push down. This one you cannot push down, but this one weakness you can push down. So he has problem where, which nerve?
Deep peroneal.
Okay. So what I need from you, verbalize to the examiner the patient on walking one by one. Once you find any abnormality, verbalize quickly. Why? Two benefits. The first one, you are showing the examiner that you catch abnormality. The second one, maybe the time will finish. And also, maybe you cannot recall everything. Okay, so one by one. So the patient has foot drop on walking. Thank you. And after that, the sensation. The patient cannot feel the lateral part of leg and the foot in the right side. So he has problem in superficial peroneal. The patient cannot feel with space in the right side. He has the peroneal. So he has common peroneal nerve problem. In motor, the patient cannot do eversion in the right side. The patient cannot do dorsiflexion in the right side. The patient cannot do two extension in the right side. He has problem in the superficial peroneal. He has problem in the peroneal. So he has problem in common peroneal. Clear, guys?
Yeah.
Yeah. Okay. And you can do the routine like reflex, also vibration, also proprioception. It will be easy for you. The most important, the walking, the sensation, the motor. Okay, and don't forget the tone. Okay, next station, guys. Dr. Ahmed Samad. Dr. Ahmed?
Yes, doctor. Hi, Dr. Hani.
Yeah, fine. You have 30 seconds.
Okay, sure.
To prepare yourself. Okay, you can start.
Hello, my name is Ahmed. I'm one of the A&E doctors. May I confirm your name and date of birth, please?
Yeah, I'm his cousin. I'm Mr. Saleh. Mr. Shaheen, he doesn't speak English. He's 28 years.
Okay, and is he happy for you to translate for him, or we can also use language line if needed?
It's okay, he can.
I mean, can you ask him if he's happy for you to translate for me?
Okay, yeah, he accepted.
He accepted that. Okay. So I need just to ask, is he comfortable at the moment? Does he need any painkillers at all?
Yeah, I am comfortable.
So he's comfortable. Okay. So right now, I need to wash my hands and I need to take PPE on. I need also to take consent from him to examine him and take some more details about his presentation. Is it right for him?
Okay.
Does he need any chaperone or anyone to attend?
It's okay.
Okay, so I understand that he come today because he has some neck pain after having some injury last night.
You can proceed with the patient.
Okay, so how did it happen? What happened exactly last night?
Yeah. Today I fell from 2 stairs.
Okay, I'm sorry to hear about that. Okay, and where does it hurt at the moment?
Yeah, I have been in the midline of my neck and lower back.
Okay, any like tingling, any numbness in your arms at all?
At the moment, I don't feel anything.
Okay, were you able to walk after that?
Yeah, I came here walking.
Okay, and are you able to sit properly as well?
Yeah.
Have you felt? Okay, have you felt pain immediately after injury or after a while?
After 2 hours.
After 2 hours. Okay. So right now I need to proceed with examination of your neck. Is it right?
Okay.
So my examination will include that I'm going to feel your neck and also I'm going to examine your arms to see what's going on. Okay?
Okay.
So I need to expose your neck. First of all, I need to have a look at your neck to see if there is any like swelling, any redness, any apparent injury, any bleeding from back and from side, from anterior part. Can I see anything at all?
No.
Okay, so I'm going to feel your neck gently at the moment. So I'm going to touch your neck. I'm feeling the midline of the neck to see if there is any significant tenderness over the spine.
No tenderness.
No tenderness over the spine. Okay. And what about the paraspinal area about around the midline? Is there any tenderness at all?
It's okay.
So no tenderness at the midline and no tenderness on the paraspinal. Are you able to move your neck like 45 degrees in both directions?
Yeah.
Okay, so there is no limitation of movement on no limitation of movement. Thank you for that. So right now I need also to examine your arms. Apparently I need to do full neurology examination of your arms. So I need to have a look at your upper limbs. Any abnormalities at all by inspection?
It's okay.
Okay, so I'm going to feel the tone to check shoulder abduction, shoulder adduction. Just keep yourself floppy, and I'm going to check the tone of your muscles. I'm going to examine elbow flexion, extension, wrist flexion, extension, and the finger movement as well. So tone looks all right. So right now I'm going to examine the power in your arms. So can you resist just abduct your shoulders? I mean, move your shoulders away and resist my action in both directions, both sides. Now, can you flex your shoulders against my resistance? Okay. Thank you. Right now, can you resist my action? I mean, flex both of your elbows and don't allow me to make them straight. Thank you for that. And now can you make your elbows straight, your arms straight, and don't allow me to flex your elbows? Okay, thank you. And also, again, resist my action to make your wrist straight. and in opposite direction, don't allow me to straight your wrist. Also, I'm going to check finger abduction and thumb movement as well. Okay, thank you for that.
There is problem weakness here in finger abduction in the right side.
So finger abduction on the right side, there is some weakness.
Yeah, I cannot resist against it.
Okay, so at this point, I prefer to keep you in a straight position and also to put some blocks on your neck until we complete our exam. Is it all right? I need just to immobilize your neck until we make sure that everything is all right.
Okay.
Okay, thank you. I'm going to proceed with my examination. So I'm going to check for sensation. So I will do touch sensation. Are you able to feel the touch on your forehead?
Yeah.
Okay, so now can you close both of your eyes? I'm going to examine sensation on both hands. So I'm going to examine level of big thumb.
Thank you. Okay, you have 30 seconds. 30 seconds means concise.
Okay, so apparently I need to complete my examination by do sensation, like cotton sensation, pinprick sensation, and also
you can do.
Okay, so I'm going to touch thumb for C6, and the middle finger for C7, and little finger for C8, and also inner aspect of the arm.
I cannot feel the little finger.
Okay.
Right side.
Okay. So yeah, and also inner aspect of medial aspect of the arm, forearm, and the medial aspect of the arm.
Okay. So what is the problem now?
So right now I feel there is some compression over maybe the lower trunk of brachial plexus, affecting the ulnar nerve. It could be secondary to the trauma. In this situation, I think we need to immobilize the neck, and we need to get proper imaging, most likely by first of all, we will do like X-ray if nothing significant because of apparent neurology. We need to consider MRI.
You will do X-ray or CT scan?
I mean, we can consider, apparently he needs MRI. Definitely he needs MRI because there is like some neurology. Even if CT is negative, still we need MRI and we need some input from neurology team.
Okay. Thank you, Dr. Ahmed.
Thank you.
Well done. Okay. Any comment, guys? Anyone want to add?
He did well, but the patient need a CT, not MRI at this time. If you find anything abnormal, then you go for MRI.
Did he examine the neck, cervical spines, and the movement of the neck?
Yes, I did. I examined the midline and I asked it for movement.
Okay.
Yeah.
Okay, thank you.
Okay, what else, guys?
Comparison
in the beginning, there should be an application of a cervical collar after checking the ABC for the patient. Checking ABC, and then it is clearly in the secondary survey.
Yeah, okay. So here, examination of the neck, it's a secondary survey, not primary survey. So you have to clear primary survey, okay? Primary survey, it means you have to apply C-collar first, right, Dr. Ahmed?
Okay, yeah.
Yeah. You did very well, amazing. And here I will give you just small points to get 10 out of 10, okay? So first of all, you recognize the patient is not speaking English. So first of all, hospital translator, okay? Not the cousin, because maybe the cousin will give you not proper information. But if the hospital translator is not available, so you have to go for the next step. The cousin will translate to, okay, after consent from the patient. Okay, so I need hospital translator. Hospital translator is busy, so you can ask the cousin, can you ask Mr. Shaheen for you to translate and to stay with us? Can you take consent from him? Okay. After that, talk with the patient, don't talk with the cousin. Clear, Dr. Ahmed? Don't waste the time.
Yeah, sure.
Yeah. In the exam, I cannot see your eyes now. In the exam, if you have two persons in the station, your eye will be with good eye contact with who? With the patient or with the cousin?
Should be with the patient.
With the patient. Even he is
Yeah.
not speaking English. Even the cousin will translate to you. So once you will continue with the patient will talk to you until you finish the station. Okay, so your communication will be with the patient. Okay, we finish this point. After that, just to verbalize, I have been informed that you have pain in your neck. So before you take history from him, you can verbalize, I need to apply. So after you know it's a trauma, can you tell me more about that? He said, yes, I fell from a stair, 2 stairs, and it was 2 hours ago. I'm sorry to feel that. Can you let me to apply this C collar to protect your neck? And would you like to give you painkiller at the moment? Are you comfortable? It's okay. So just to verbalize to the examiner, I want to be sure that the airway is clear, or you can say the primary survey is clear. Okay. After that, you can proceed. Okay. You can do what you want as you did with us. It's very amazing. Okay. And here, examination. Yeah. In examination, you can check if the tone, okay, like shoulder, okay, you can check the tone, the floppy or not, okay, and after that, don't let me to push down, don't let me to push up, the same as we did in shoulder examination, okay, and sorry, in upper motor examination, in neurology. So the same. If the patient has problem in this one, it will be radial. This one will be ulnar. This one, it will be median. So here, it's not a big issue if you don't know which nerve, right?
Yeah.
In this station, it's a neck examination. It's not a big issue if you don't know which nerve. Why? Because here, it's not neurology examination. For example, someone will know this is radial. Another one doesn't know. Not a big issue because it will not affect the management plan. The management plan here, if the patient has any nerve injury after neck trauma, so you have to go for cervical collar again, apply as you did. After that, you can do CT scan. According to Canadian spine, it's a CT scan, not MRI. I agree with you for neurology should be MRI. But the first step in Canadian, it's a CT scan. If you don't find any abnormality, you can do MRI. Or if you want to do MRI later, it's not a big issue. So here, radial, ulnar, median. Don't forget that. And here, no need for all neurology examination. Dr. Ahmed, you have to do motor and the sensory and the reflexes only. So sensory, I wish if you ask me, can you feel that? Can you feel that? C5. Can you feel that? Can you feel that? T1. Can you feel that? Can you feel that? C6. Can you feel that? Can you feel that? No. The patient has problem in C7. The radial nerve not intact. I'm giving you example, okay? Can you feel that? Can you feel that? Yes. So the patient has intact median, intact ulnar, and abnormality in the median nerve. Okay. So you have to verbalize like that. And here you did very well regarding the Canadian spine. From the start, you have to exclude if the patient more than 65, if the patient has dangerous mechanism of injury, if he has paresthesia in extremities. You ask me already, the patient doesn't have, but on examination, you find weakness, okay? Because here, weakness not mentioned in the history, right?
Yeah.
Yeah.
But
So
I think I should consider also C-spine immobilization from beginning because of dangerous mechanism of injury.
This is what we mentioned. Okay.
Yeah.
So I want to apply C-collar to protect your neck until I finish your examination, your exam. After that, I will see if I will remove or not. I will see if you need imaging or not. They said here radiography. Did they mention X-ray or CT scan?
No, they haven't.
Okay, so you can verbalize to the patient. I will see after examination if you need radiograph or not. Done. Okay, you did very well, but just these small points. Clear?
Thank you, Dr. Han.
Yeah, amazing. But please, please, guys, the most important here, only motor, sorry, the tone, after that the motor, after that sensory, after that you can clear if need radiograph or not, if you need to remove C-collar or not. Okay, no need to do everything. No need for vibration, no need for proprioception, no need for other upper limb neurology. Clear, guys?
Yes, sir.
Next
regarding,
one.
sorry, regarding clearing Canadian C-spine in the primary, so before starting the examination of upper limb or after the examination, sir? I confused. I was confused.
Yeah, excellent. So here you can ask about high risk factors. Okay. Is this clear for you? I'm sure.
Yes, sir.
Yeah, you don't have high risk factor, so you can go for low risk factor. Okay. After that, the patient already in sitting position. No need to continue. Okay. No need to continue. So I wish if Dr. Ahmed said like that. Now you are in sitting position, and this is good news. This low risk. Okay. Criteria. So can you rotate your neck 45 degrees to the right and the left? No need to check for anything else, right?
Yes.
Because they said here, any of high risk, you will do radiograph. Yes. If none, you will go for low risk. Anyone. So no need to check the 5 points. Okay. If the patient in sitting position, I said to him, I am in sitting position because I want to save time for him. Okay. So you can verbalize to the examiner. The patient is sitting position, it's a low risk criteria. So I will go for rotation. Can you rotate? So verbalize to the examiner. After that, communicate with the patient. This is how to be professional in the exam. Okay. Okay. So the patient is sitting position. So the patient has one of the low risk criteria. I will go for rotation. Can you rotate your neck 45 degrees to the left and then to the right? Yeah, excellent. So according to Canadian spine, I can clear cervical spine. So no need for radiography at the moment, and no need for collar. Okay. So you will continue examination. Okay. After that, at any time in examination, if you feel the patient has what is this? The patient has any neurological abnormality, you can apply C-collar again, and after that, you need CT scan.
Okay, sir. Thank you. Understand. Yeah. Thank you.
Okay. Next station, Dr. Raji.
I am the one.
Okay. You can start.
Okay. Hello. I need to wash my hands. Hello, I'm Dr. Rajlakshmi, ED Register. Can I confirm your name and age, please?
Ayman, 37.
Okay, nice to meet you, Mr. Ayman. I have been informed that you have some back pain after injured last night. Is it right?
Yeah.
Can you tell me more about that?
Yeah, I felt from stairs last night, and I slept. Today I have back pain in the midline in the lower part.
Okay. Are you comfortable now? Do you have
Yeah,
any
it's
pain?
okay. I took
Okay.
painkiller.
Okay. Okay, Mr. Ashman. I have been asked to take some the data, small data, and do some examination of your back. And this going to be involve look, feel, and move, do some special test on your back. Would that be okay with you?
Okay.
And throughout the examination, it will be take place in a private room, and I'll ask my one of the nurse to stay with us. Would that be okay?
Okay.
Okay. Can you tell me, do you have any numbness in your limbs? Do you have any, did you notice any change in your sex drive? Okay. Okay. Did you notice any bowel or bladder changes? Okay. 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 Okay, Mr. Eisman, I'm going to start the examination. For that, I need you to expose your upper body, and your privacy will be preserved. Would that be okay? Okay. Can you please walk few steps for me? I'm going to observe the abnormality of any gait disturbance. Okay. Can you please lie on the couch, please? I'm going to have a look. I'm looking for any asymmetry, swelling, scars. Sorry. I want you to stand straight for me. I want to look from back, sides, looking for any asymmetry, swelling, scars, fasciculation, any injury. And Mr. Eisman, I'm going to feel your back from the below your neck to bottom. Let me know if you have any pain, and I'll also look the patient eye for any tenderness. And I'll also feel the paraspinal muscle for any tenderness or any spasm. Okay, Mr. Ashman, I want you to do some movements for me. Can you copy the movement? Can you extend your neck like this, neck extension? Can you do like this for me, neck flexion? Can you do like this for me, neck rotation? Can you do this for me, lateral flexion? Can you bend forward for me to touch your toes? Back flexion. Can you bend backward for me? Extension. Can you try to touch your right toe with the right hand? Thoracic flexion. Same on the other side, please. Can you please sit on the couch and cross your arms? Do a rotation to the right and left for me. Thank you. Mr. Rashman, can you please lie on the couch, please? I want to do some special test on your back. Is it okay? Are you comfortable now?
Yeah.
Okay. Now I'm going to raise your leg and let me know if you have any pain. And also I'll look at the patient eyes for any tenderness. And I'll raise the right leg and 45 degree, and also I'll dorsiflex the dorsum. And I want to do the same movement on the other side. Straight leg rising test. And Mr. Ashman, can you please lie on your tummy, please? Now I'm going to bend your knees. Let me know if you have any pain. I'm doing it on the right side. And I want to do the same on the other side. Femoral stretch test. Do you have any pain?
No.
Okay. Thank you, Mr. Eichmann. I have completed my examination. Is there any abnormality in any examination finding?
You can continue.
Okay. Thank you, Mr. Eichmann. I have completed my examination. Let me.
You can do sensory.
Yeah. Okay, Mr. Ashman, I want to do the sensation of your, I want to check the sensation of your lower leg. Can you please lie on the couch for me? Can you feel the cotton piece on your forehead? This is going to be feel like this. Can you close your eyes? I'm checking for a T1 and also I'll compare it on the both side. T2, sorry, L1, L2, L3, L4, L5, S1.
Okay, the patient has bilateral sensory loss in L4 and L5.
Okay, 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 bilateral. Okay, thank you, Mr. Eichmann. I have been completed my examination. Let me help you to redress. Are you comfortable now?
Thank you, Dr. Raji. I'm the examiner now. What is your diagnosis?
Like, I can find there is a loss of sensation in the both lower limbs. So it could be a Carda equina syndrome because of trauma. There could be a low compression of lower motor nerves in the lower back.
So what is your management?
I want to do a MRI for this patient and I'll also refer you the patient to neurosurgeon immediately.
Okay, so you will keep the patient lying or standing or sitting or what?
Now I want to make the patient lying.
Okay, so you will keep embolization of the patient.
Yeah.
Okay, and the MRI after that refer to neurosurgeon.
Yes.
Okay, thank you.
Thank you.
Amazing, Dr. Raji. What I need from you, be clear in the questions in the history. Just ask the questions of Koda equine. Numbness here, you will get data or you will do examination for numbness.
Examination.
So no need to ask the patient for numbness, right?
Okay, sir.
Anything you will get from examination, no need to ask. Okay. So here regarding bowel, you can explain to the patient in your question. Should your question be clear? Communication here should be very clear to the patient. So any problem in bladder, like what? Like constipation, incontinence.
Okay.
Any problem in bowel? So in bladder, like retention or incontinence. Any problem in bowel, like constipation, incontinence. Give him example, he will choose. Okay? But if you will say any problem in bladder, he doesn't know. Like what? Maybe he think burning micturition, right? It's irrelevant here, right?
Yeah.
Yeah. So I want you to be focused. Tell him specific question. Close the question and declare questions. Okay. Any problem in your sex? Because sorry to ask you this question, it's very important. Okay. So he will answer. Maybe he will say yes, I have problem. Okay.
Yes.
Yeah. Regarding numbers, you can examine for sensation. The most important sensation in the end. If you still have time, you can motor. Okay. Yeah, if you still have time, you can do motor and lower limb. But you have to ask also in the history, in the start, is this pain spread to your lower limbs?
Okay.
If he said yes, so it's a Koda equina. If he said no, it's not. Okay.
Okay, sir.
Yeah, from the start.
Okay.
Well done. I will just repeat what you did. So from the start, after consent, after everything. So I will, and can you stand for me and expose your upper and lower body? You can wear only the boxer. So I will check for from front, head, neck position, symmetry of shoulders, okay, cervical lordosis from the side, thoracic kyphosis, lumbar lordosis. I want to verbalize like that. From behind, I will check for any scars, muscle wasting, scoliosis, abnormal hair growth. Okay.
Okay.
Can you walk for me? I will check the gait. Okay. If you find the gait is normal, you can say the gait is normal. If you find the patient is doing Trendelenburg gait, so you can verbalize that. If you find antalgic gait, you can verbalize the patient has antalgic gait. Okay. So anything you find, verbalize. Okay, Dr. Raji?
Yes, sir.
Yeah. Normal walking or normal gait, the patient has normal gait.
Okay.
The patient has abnormal gait, you can verbalize to the examiner, right?
Yes, sir.
So any finding, you even normal, you can say to the patient, to the examiner. After that, I will feel your back for any tenderness looking at the eyes of the patient. You should check the eyes of the patient. So you have to be beside the patient, not like that, not behind, beside the patient. So your eyes checking his eyes, and you can check the midline and the paraspinal. Okay. After that, can you move your neck like that? 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 It will save time. If you will ask the patient to do like you are doing, it will save time for you. After that, can you bend your back and touch your feet? So verbalize to the examiner lumbar flexion. Can you bend your back behind? So lumbar extension. Can you touch by sides like that? You can do for the patient once. Lumbar lateral flexion and the other side. So if you will do to the patient and he will copy from you, it's good. It will save time. You can ask the examiner, the patient from the start, can you copy from me? Can you do like that? Can you do like that? It will save time. And here, can you sit down and cross your arm and turn to the left, turn to the right? Here also, what is this test?
Showbus test, sir. I forgot.
Yeah, that's why I'm asking you. So very, very important.
Okay.
Okay. Yeah. You have to explain to the actor. You will get marked for simple explanation. Okay. So I will do 3 marks on your back by this pen. You don't have pen, but verbalize, just verbalize, right?
Okay, sir.
Yeah. Sorry, I will do 3 marks by this pen on your back. It's very important for us. Take consent for that. Very quick consent. Okay. So explain to the examiner. The first mark will be where?
Posterior iliac spine, the line joining the posterior spine.
Excellent. Posterior iliac spine. And the upper mark will be how
10
long?
centimeter above and 5 centimeter below.
Yes. 10 centimeter above, 5 centimeter below. And ask
the
him to
patient
bend. Can you touch your feet? I will check the distance between upper and lower marks. The normal should be?
More than 20 centimeter.
Yeah. Okay. So after that, you will do a straight leg raise. And after that, you will do for the leg. After that, for the dorsiflexion for the toe. Okay. This, if he has pain, it means sciatica. Okay. Yeah. So if he has, how to understand this sciatica and not coda equina? Anyone can answer?
Bilateral versus
Bilateral
bilateral.
Leg
Sensation.
raising test is
Sensation
positive,
and-
while the sensation and the other are motor
Motor.
power is intact.
If the patient has this test positive, it's sciatica. If one limb, it's unilateral sciatica. If he has a positive test in bilateral, so it's a bilateral sciatica, right?
Yes, sir.
Bilateral sciatica. And if he has sciatica, whatever unilateral or bilateral, he doesn't have problem in bladder. He doesn't have problem in bowel. He doesn't have problem in sex drive. And sensory, when you do examination in the end of the station for sensory, he has intact sensation. So it's a sciatica, right? Okay.
Okay.
Yeah. But if the
Dr. Hani,
patient,
can the examiner, just a question, can the examiner tell us from the beginning, for example, that if we ask about the bowel dysfunction or urine incontinence, he say he doesn't have a problem, but later on with the sensation, there could be loss of sensation. Could it be like a partial coda equina or something like that? Or from the beginning, the examiner has to tell us that he's having bladder dysfunction?
if he denied the patient, not the examiner, if the actor denied bladder or bowel or sex drive normal, he denied everything. So you ask him clearly, is this pain spread elsewhere, like your lower legs? If he said yes, most likely it's a coda equina.
But
Okay.
also we'll check the sensory, yes, 1, 2, 3. So that also gives an idea, no?
Yeah, in the end, okay. So if the patient doesn't have pain lower limbs, unlikely to be coda equina. Okay. If the patient has only pain when you are doing the test, it's sciatica. But if he has lower limb pain bilateral, it's coda equina from the start. Okay.
Okay.
Yeah, it's clear. So if the patient denies every criteria of coda equina and he has positive straight leg test, whatever in one limb, it's unilateral sciatica. If he has positive test in both sides, that's why you have to do the test in both sides. Don't say ideally I will do in both sides, but for the purpose of the time, I will do in the affected one. No, here you have to do on both sides because you want to check the patient has unilateral sciatica or bilateral sciatica. Okay, so this test is positive sciatica. Okay, so ask the patient, do you have any pain in your pelvis? Okay, so pain
So
in the
Dr. Hani,
posterior.
bilateral sciatica is coda equina?
No,
He's having bilateral, or still it
different.
is bilateral
No.
sciatica?
No. Bilateral sciatica different than coda equina.
Okay.
Okay, coda equina, it means there is compression on the spinal cord. Okay, so here, if you find bilateral lower limb pain without any test from the start, clear, Dr. Ahmed?
Yes, Dr. Hani.
Yeah, coda equina, the patient has back pain, and this pain is spread to lower limbs without any test. He has pain already, okay? But sciatica, the patient has pain in the thigh or buttock when you do straight leg test. Clear?
Yes, clear.
Yeah. If he has unilateral, it's a unilateral sciatica. If he has positive test in both limbs, so it's a sciatica bilateral. Okay. If he has this test, femoral nerve stretch test, so you can ask him, can you bend on your tummy? I will do the same test. So ask him if he has pain in the anterior side inguinal region, it means femoral nerve problem. So this one sciatica, this one femoral nerve, this one sciatic nerve, this one femoral nerve. Okay, I think it's clear now. Okay. After that, you will do a sensory test. So can you feel that? Can you feel that? Can you feel that? So if you feel everything, it's unlikely to be coda equina. And of course, you exclude all criteria of coda equina. If he has sensory loss, it's coda equina, bilateral. Clear, guys?
Yes, sir.
Yeah. So you have to do a sensation in the end. Can you feel that? Number 2. Can you feel that? Number 3. Can you feel that? Number 4. Can you feel that? Number 5. Can you feel that? Can you feel that? Done. So if everything normal regarding coda equina, the patient doesn't have lower limb pain. The patient doesn't have bowel or bladder problem. The patient has normal sex function. The patient doesn't have sensation problem. So it's not coda equina. I can rule out coda equina. Okay. Okay. If the patient has coda equina, so MRI and refer to neurosurgeon now. Okay. Well done. Next one, who will do the next station, guys? If not, we can repeat from the start. Anyone want to do the next station?
I can do Dr. Hani. I'll raise my hand.
Okay, who is this?
Hussam Baliti.
Okay, Dr. Hassan. You have 30 seconds.
Okay, good morning. This is Dr. Hussam, ED Registrar. May I confirm your name and age, please?
Hi, Sam, 35 years.
Nice to meet you, Mr. Haytham. Are you on pain, Haytham? Are you comfortable? Can you offer you a painkiller?
It's okay.
Okay, Haytham, how can I help you today?
Yeah, I have shoulder pain. I fell from stairs last night.
I'm very sorry to hear that. Can you tell me it's right or left shoulder?
Right.
Okay. Do you have any other symptoms?
No.
Any past medical history, Mr. Haytham?
No.
Do you take any drugs or have any allergies?
No.
May I know when was your last meal and drink, please?
Like 4 hours.
Okay. Mr. Haytham, do you mind if I do some examination for your shoulder, please?
Please.
Okay, I would like to expose your arm and trunk area. My examination will include inspecting, looking, feeling, touching your shoulders, and do some special tests. Okay?
Okay.
So I will start by inspecting the shoulder from anterior side, posterior side, and lateral side, looking for any scars, deformity, any abnormalities by inspections. And at the end, I would like you to put your hands against the wall, please, for me. I will check for this any winged scapula, which may indicate long thoracic nerve injury. After finishing the inspection, I would like to touch your shoulder here. I will start by touching the sternoclavicular joint. Check if there's any tenderness. Would this mean that there's tendonitis? Go through the clavicle, then acromion head, then the humeral head, and greater tuberosity of the humerus. And at the end, I would like to palpate the scapular edge as well from the back. Okay, if there's no tenderness, then that means there's no signs of tendonitis. Now I would like you to follow me, Mr. Haytham. Please do like this. I will flex the shoulder joint. Please do like this. Extension of the shoulder joint. Please do like this. Abduction. Please do like this. Adduction of the shoulder joint. Please do like this. External rotation of the shoulder joint. Please do like this. Internal rotation of the joint point. I examined the active movements. Now I'm going to do this movement again by myself for you. I want you to keep your hand free, flex, and I will do it for you. I will check for the tone here. I will do abduction, adduction, internal rotation, external rotation, and extension and flexion for the shoulder joint. Okay, good, Mr. Haytham. Now I would like to do some special tests for you. Okay, I will start by, can you please raise your hand up, flex your shoulder up, and I want you to keep your thumb facing down to the ground. The maximum that you can go up. Let me know if you feel any pain in your shoulder. Okay, I'm testing for doing the near test here, testing for the supraspinatus muscle. Okay, that's good, Mr. Haytham. Now I would like you to raise both of your arms up 90 degrees and thumbs down as well, facing the ground. And please don't let me push down, okay? Now I'm doing the empty can test again to test for the supraspinatus muscle.
There is no resistance in the right side.
Okay, so empty can test is positive on the right side. Okay, now I would like to raise your hand up, Mr. Haytham, like this, and I would like to observe if there any drop in your arm. Okay, I'm doing the drop test here. Okay, I will move now to test the infraspinatus and the teres minor muscles. I would like to please do like this, Mr. Haytham. I will flex his elbow. Don't let me push inside, okay?
I will test the external rotation against resistance. This is for the spinatus. Then I will.
There is no resistance in this test in the right side.
Okay, so external rotation resistance is positive in the right side. Okay, now I will move into I would like you to flex your shoulder 90 degree and flex your elbow as well 90 degree and touch your other shoulder. I will push through the other side. Let me know if there's any pain in this area here in the shoulder. I'm doing the scarf test here, which indicates if there's any acromioclavicular joint pathology. And I will finish up by testing the subscapularis, which is internal rotation. I would like you to do like this for me, please, Mr. Haytham. Put your hand on your back and don't let me push inside, okay? I'm doing internal rotation against resistance here. Okay,
there is
to test for the
no resistance in this test in the right side.
Okay, so suprascapularis internal rotation positive as well on the right side. Okay, so Mr. Haytham, I would like to inform you that I finished my examination here. Now, based on your examination and your presentation, I am suspecting that you have problem with your muscles of the shoulder here. Since there is no resistance, so this is most likely a tear, a partial tear in your rotator cuff. This is what we call the rotator cuff injury, rotator cuff tear. For this, Mr. Haytham, I would like to do a complete nerve examination for your upper limb. I'll also like to do a general physical examination, run some blood tests for you.
Thank you.
And
thank you. Okay.
Thank you.
Well done, Dr. Hassan. What is your management?
So my management is to I will consult orthopedic team as he may have a tear in his rotator cuff muscles, and based on I would most likely do an MRI for him, maybe me or the orthopedic team, but he needs some sort of imaging.
Okay, so.
And then prescribe him painkiller, of course. I don't think that I can discharge him because it's not a simple impingement.
Okay, sure. Okay, well done, Dr. Hassan. Let me to give you a comment. Okay, so well done, amazing. I care about your findings. Okay, so any finding you find, you can verbalize to the examiner. I said there is no resistance here, right? So you can verbalize there is supraspinatus tear. Okay, so I said in the next test there is no resistance here. You can say subscapularis tear, right?
Right.
Yeah, so anything you find, verbalize to the examiner. Okay, from the start you did very well. So can you stand for me, please? I will check for any asymmetry, any deformity in wasting, for also position, head, neck, shoulder, posture. Okay, so relation between 3 points. After that, you have to comment on the deltoid, and from the side, comment on the deltoid. You have to mention the deltoid. Okay, so I will check for any wasting of deltoid, more than enough if you will mention deltoid. In the back, I will check for head, neck, shoulder, posture. I will check for asymmetry, deformity of deltoid, trapezius. Done. So here you are checking for deltoid and trapezius. From the side, deltoid. From the anterior, you can mention deltoid. Okay? Okay. So be focused on your examination. In the knee, what you are checking, blah, 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 blah. In the shoulder, what you are checking. It's not about asymmetry, deformity, wasting. No. Checking for what exactly? Okay? And quickly. Okay. After that, can you put your arms straight on the wall? I will check for winging of scapula. Thank you. And I want you to mention always thank you, thank you, thank you. Okay. Otherwise, he will stay like that. Okay. So thank you, it means done, and you are thanking the patient as well. Okay, after that, I will feel temperature. Any joint you will feel for temperature for arthritis, for septic arthritis, or any inflammation. By dorsum of my hands, I will check for tenderness, looking at the eyes of the patient. Okay, so you have to check his eyes by your eyes. Here, the actor sometimes is looking at your eyes also. He's checking you are looking at him or not. He will give feedback to the examiner. Okay. After that, can you put your hands behind your head? Can you put your hand behind your back? Can you copy from me? Can you do like that? Can you do like that? And each one you can verbalize the action. So this one is, guys,
Flexion. Shoulder flexion.
extension. This one, extension. Okay. This one,
flexion.
Sorry, flexion. Extension. After that, abduction. After that, abduction. After that, external rotation, internal rotation. Can you raise your arm? I will check for movement of the scapula. Okay. So the special test, of course, you will do the same test, but passive. So I will do the same for you. Please relax, and I will do the same for you. Okay. After that, you have special tests. This one for supraspinatus, this one for supraspinatus, this one for supraspinatus. So we have 3 tests for supraspinatus. Okay. How to do that? Here, first of all, check the movement of abduction. Don't do this test or this test before this test. It's not logic. So you have to check the range of movement first of the patient. Can you raise your arm up 180 degrees? So from 0, this 0, and here 180 degrees. If the patient has pain on 180 degrees, what does it mean, guys?
Impingement.
Acromioclavicular joint pathology. Okay. Impingement, it means pain on movement. Okay. So here, can you move your arm up 180 degrees and tell me if you have any pain at any time? So if he has pain on 180 degrees, it's acromioclavicular joint pathology. After that, ask him to slow down or lower down the arm slowly. And here you have to put your arm down. Maybe it will fall, maybe it will drop. That's why this test is called drop test. Okay. So if the patient has, what is this degree, guys? This one.
60.
60 degrees. And this degree?
120.
120. Excellent. So if the patient has pain between 60 and 120, so what does it mean?
Supraspinatus problem.
Supraspinatus impingement. Okay. If the patient, his arm dropped, what does it mean?
Supraspinatus
tear. Because he cannot control. There is weakness or paralysis. Okay. So he cannot control his muscle. So it means a tear. So again, if he has pain in 180, it means acromioclavicular joint pathology. If he has pain 60 to 120, means supraspinatus impingement. If he has drop, so it means supraspinatus tear. After that, you can do this test. Okay. So
Dr. Hani, this is the drop test. Is it active or passive? I will do it for him, or he will raise his hand.
Sorry, active. He will do for himself.
Oh, okay.
Active. It means the patient will do for himself. Don't do for him. Okay.
Okay.
Can you raise your arm 180 degrees and lower your arm slowly? Okay. If you have pain at any time, tell me. So if he has pain in 120 up to 60, It's called supraspinatus impingement, or sometimes they are calling painful arc. Painful arc. So painful arc, it means supraspinatus impingement. Okay. Okay. So here, don't let me to push down, and your eyes check his eyes. His eyes check your the eyes of the patient. Okay. So if the patient has no resistance, it means supraspinatus tear. If the patient has tenderness on his eyes, it means supraspinatus impingement. Okay, I think it's clear. This test, no need for this test, because the same, near the test, you will do internal rotation. Okay, if the patient has pain, so the same test, but here, don't let me to push down, but this one, you will do internal rotation and check his eyes. If he has pain, it means supraspinatus impingement. So this one and this one more than enough.
Yes,
okay. Yeah. This test regarding the scarf test, no need. If the patient, this one for acromioclavicular joint pathology, if he has pain in 180 degree, it means acromioclavicular joint, and this indicate to do this test. If he doesn't have pain on 180 degree, no need to do scarf test. Okay, don't be scripted. I want you to understand what to do. Okay, to save time. So here, don't let me to. Can you do like that? Don't let me to push inside. He has no resistance. So which muscle, guys? This one.
Teres minor, infraspinatus.
Infraspinatus and teres minor.
Teres minor and infraspinatus. So you can verbalize to the examiner. The patient has a this test is called external rotation resistance. So it's a positive. It means teres minor and infraspinatus muscle tear. And this one, can you do like that for me? Put your hand behind your back. Don't let me to push inside. So no resistance. So the patient has subscapularis tear. So what is the name of the test, guys? Lift off test. Okay.
Gerber's lift off.
Yes. Okay. So if the patient has any of them only tenderness, so it's impingement. But if he has tear, it means weakness or no resistance. So if he has only one positive test in one muscle, mention the name of the muscle only. If he has problem in all muscles, so it means he has rotator cuff injury. Rotator cuff, it means 4 muscles. It means the shoulder muscles. So he has supraspinatus problem, infraspinatus anterior minor problem. He has subscapularis problem. So if he has tenderness in all muscles, guys, what is the diagnosis?
Rotator cuff impingement.
Excellent, rotator cuff impingement. If he has weakness or no resistance in all muscles,
Tear. Tear.
Tear where?
Rotator cuff tear.
Rotator cuff tear. Okay. So this is how to get 10 out of 10 in this station. Okay. Next station, who is happy to do that?
Dr. Enes, sorry, one question.
Yeah, sure.
When I do the drop test, patient feel pain at the 180 degree. Should I confirm with scarf test or no need for scarf test?
Yeah, regarding regarding a scarf test, no need to do if the patient doesn't have in 180 degree.
If patient have pain,
so you have to do. You have to verbalize.
I have to confirm.
Yeah, the patient have pain on 180 degree means acromioclavicular joint pathology. After that, you can start by scarf test to be logical.
Okay. Thank you, doctor.
Before supraspinal.
I will do, Dr. Hani, this one.
Okay, and here I have one point regarding feeling. So if you will do feeling, so feel temperature, after that tenderness. Any tenderness, it means tendonitis. So if the patient doesn't have impingement, the patient doesn't have weakness or tear, so he has only tenderness on palpation. What does it mean?
Tendonitis.
Tendonitis. Okay, I wish it's clear.
And Dr. Hani, the management for the tear is conservative or does it need operation? What's the management plan?
This patient, he has trauma, right?
Yes.
So X-ray first, okay? If the patient has trauma, verbalize X-ray. If he has tear, this needs X-ray first. After that, if you find a fracture, you can give possibility to the examiner. Okay, in the last minute, you can verbalize to the examiner. The patient has trauma, and the diagnosis is rotator cuff tear, for example, or injury. So you can say, I need to do X-ray, do complete examination, and if I found any fracture, I will refer to orthopedic. If I find a normal X-ray and the patient has a cuff injury, I need to do MRI. Okay.
Okay.
Yeah. Okay. Next one, Dr. Tarek.
Okay.
You can start.
I will wash my hand and verify. Hello, Mr. I'm Dr. Tariq, one of the senior doctor in ER today. May I know your name and age, please?
Yeah, hi, I'm certified.
I've been asked that I have to examine your hand, and you have some problem. Can let me know about your hand before I will examine.
Yeah, I injured my hand. I was in the kitchen and I cut my hand, right side.
I'm sorry to hear. When did it happen?
Yeah, 1 hour ago.
1 hour. Do you have any allergies? So I will offer a painkiller for you.
I took painkiller, doctor.
Okay. Do you have any past medical or surgical?
No.
Okay. So first of all, I want to know that which hand is your dominant hand first?
The right side.
Right side. Okay. So I will examine you, and I need to expose your hands until your elbow joint. So I will, first of all, I will look, and I will feel, and I you can stop me. Is it okay with you?
Okay.
From the look, first of all, I will look. Can you do your hand like me? Pronation. And put your hand on the pillow, please. Okay. And I will look, first of all, abnormal. I will look for any asymmetry of the hands bone, and I will see any splinter hemorrhage, any Burkhardt nodules, and Heberden nodules, and I will see any deformity on the pronation dorsum of the hand. It's okay now. Please, can you do this supination for me? I will see that any palmar erythema, and I will see any abnormality on the hand, any cut or any swelling, any wasting of the thenar or hypothenar muscles. Normal, look is normal. Okay, so after that, I will feel the temperature on the both hand, first of normal and then on the affected hand. Yeah, I will feel the temperature on the palm, and I will see on the wrist also as well as, and I will go on the dorsal side, and I will see the temperature on the dorsum of the hand. And after that, I will feel with my thumb the thenar muscles, any wasting of the thenar and hypothenar muscles, and I will see in between on the palm there is a contracture of the any muscles in the palm. And after that, I will go for the examination that I use called movement of the hands. Is it okay? And can you please do for me like this: flexion of the wrist, extension of the wrist, medial rotation, and lateral rotation. Is it okay? Now I will go for the passive movement of wrist and hand. And passive movement of flexion, extension, medial and lateral rotation. It's all are the normal. And after that, I will go on the back side of the dorsum of the hand, and I will feel that the styloid process of the radial and ulna also. And I will feel that there is tenderness, then carpal bones on all the 8 carpal bones. Then I will go for the metacarpal bones. I will see that any tenderness or any swelling on the carpal bones. And after that, I will go the proximal and distal, proximal joint and distal joint of the fingers, one by one, bilaterally, all the joints. I will see there is any swelling or any tenderness of the joints. After that, now I will ask that, can you please flex your elbow for me? And I will see that any rheumatoid nodules, any psoriatic plaque on the back of the forearm. And it looks normal there is. And after that, I will ask that he has to do the flexion of the elbow and flexion of this extension. Now I will go for the special test that I will ask. First of all, I will see that there is any neurological deficit. There are 3 nerves, especially that I have to examine as feel the sensation, especially on the median nerve, radial nerve, and ulnar nerves. And I will take the cotton and I will ask that, please, can you close eyes and you feel like this? So when you feel okay, let me know. And when so I will feel sensation on the both hand. And I will start from, please, can you close the eyes? And I will see on the, first of all, on the tip of the first radial side of the tip of the first finger, do you feel it? So I will ask him. And then after that, I will see on the little finger, on the medial side of the little finger, and the tip of the medial side of the little finger. And then I will ask him for the radial nerve to see on the first web, if it is do you feel like this? And I will ask him if you feel it's okay. Normal,
I can feel all.
Oh, you can feel all?
Yeah.
Okay. Now I will go, I will see that, especially basically where is any cut wound is there. On inspection, I didn't find any wound, please. Okay, this is on the middle finger. So,
okay, thank you, Dr. Tarek. Thank you.
Just
you have 60 seconds.
Okay, I will. Now I will feel that there is a flexion because there is a cut wound here, and I will ask him that I will I will fix the 3 fingers, and I will allow that this there is a cut that flex the distal proximal phalanx, and there is a flexion of this one. After that, I will put hold this extent distal joint, and I will ask flex. All are normal flexion, both proximal and distal joint.
I can bend my finger here, and I cannot bend my finger
here. Okay, it looks like that you have a flexor digitorum superficialis tendon. There is injury. So for this reason, I will ask my hand surgeon. I will call him and to examine you. Maybe there is some any tear of this tendon. So it's okay with you.
Okay, thank you, Dr. Tan.
Okay, and I will do the X-ray to find out any foreign body.
Okay, thank you. Okay, this station, it's a trauma or non-trauma?
This trauma.
Trauma. So I will do examination for trauma or non-trauma?
Trauma.
Trauma, okay.
Yeah.
So here, no need to check for elbow for any thing for rheumatoid arthritis, right?
Okay, no need. Okay.
No need. Okay. If you will do examination for everything, it means the examiner will understand that you don't know the station. Did you get my point?
Yeah.
Yeah. Focus here. The patient has wound. Okay. Here. In the exam, you will find mark here like wound. They will draw mark on the palm of the hand. So what do you need from this station to check if he has this wound fracture of the bone here, or cartilage, or the joint, maybe injury to the tendon, maybe injury to the nerve, right?
Yes.
So the patient, if you ask the patient, can you do like that?
Yeah,
me?
this I remember, but time finished.
Yeah, from the start, you will start by inspection. Can you put your hand on the pillow? I will do inspection and palpation. Done. And can you turn on? So I will check for inspection, palpation also. Inspection, I can see wound here. Where? 1 cm proximal to which finger? Middle finger. Okay. So here you have to expect maybe injury to nerve or tendon or bone. Okay. So after that, after you finish inspection palpation, ask the patient for movement. Can you do like that? The patient cannot move the middle finger, right?
Yeah.
So he will bend the left side, he will bend the right side, all finger except the middle finger. Okay?
Yeah.
Okay. And here he can do, here he can do. Okay. This one he can do. After that, you will do for the patient. Please relax. I will do for you. You will do that. You will do that for him. You will do that for him. You will do that for him. Okay. So after that, don't let me to push down. Here you are checking nerves, right?
Yeah. Yeah.
Okay. So this one, you are checking he can move the finger or not. He will not. Okay. So from the start, if the patient can bend all fingers, do you need to continue?
Oh.
No need. If the patient can bend all fingers, no need to continue examination. But because he cannot bend the middle finger, you have to continue examination. Okay. And from the start, I can see 1 centimeter proximal to the middle finger. I need to do dressing before examination and give local anesthesia. This is how to get 10 marks in the examination. This is the difference between you and the other candidate. Okay. So I will clean the wound, do dressing, and painkiller local anesthesia. Why? Because you need to do examination. Painful. Okay. So we finished this part. After that, we will check the nerve. Why you don't ask the patient? Why not explain to the patient? I want to examine nerves, so the examiner will understand also. I want you to be professional, guys. So don't let me to push down. Radial nerve intact. Don't let me to push inside. Can you splay your fingers like that? Don't let me to push inside. What is this nerve, guys?
Ulnar nerve.
Ulnar. So verbalize to the examiner. The patient has resistance, good resistance. Here he has good resistance. You will do for left or right. He has one in the right. You will do in the left or in the right first?
The left.
Yeah, the right. Should be the normal
Left
side first, then the
the normal side is left. Okay. So you will do in the left side first. So excellent. After that, do in the right. Excellent. You verbalize to the examiner. He has intact radial nerve. Can you do like that? Don't let me to push inside. Excellent. Can you do like that in the other hand? Don't let me to push inside. And I want you to be very fast. Okay. Okay. So intact ulnar nerve. Can you do your fingers up, thumb up? So don't let me to push down. Excellent. Here. Excellent. So median nerve intact. So he has intact ulnar, radial, ulnar, and median. So the problem not in nerves, right?
Tendon.
So most likely tendon. Okay. So we will check the function. Can you grab my fingers by both hands? Excellent. Can you grab my fingers by 2 fingers, thumb and the index? Excellent. Can you pick up this coin? Excellent. You don't have coin in the exam. No worries. Just pretend. Can you pick up this coin? Excellent. By the other hand, excellent. Okay. I will check for tendons. You have to test. You will hold the middle phalanx here by the left hand, and you ask the patient, can you bend your finger? Here he can do, okay? And after that, so you can say flexor digitorum profundus intact. Here, can you bend your finger? He cannot do. So you can verbalize the patient has flexor digitorum superficialis problem or injury. So you can, here for median, you can do also nuance. So tunnel and funnel, okay. Okay, so for median nerve, but it's not very, very important because already the patient has intact median nerve. I prefer if the patient has problem in median nerve, you can proceed for median nerve. Do you agree, guys? Okay, but if he has intact median nerve, no need to waste the time with this test. Okay, so here how to save time and how to get 10 out of 10. Verbalize to the examiner what you are doing. So I will check your nerves in hands. Okay. Do you need to do test here for rheumatoid arthritis, Dr. Tariq?
No.
No need. So no
Time
need to,
wasting.
yeah.
Time wasting.
Time wasting, and also the examiner maybe decrease your marks. He will think you don't understand the station, right? Okay. I want you to play on the global marks. You have 5 marks from the examiner. Okay.
Inshallah.
Yeah. Okay. So here's the most important. I want you to show the examiners that you are professional. I will examine the nerves in your hands. Can you do like that? Don't let me to push down. Intact radial nerve. Can you do like that? Don't let me to push inside. Intact ulnar nerve. Can you do like that? Don't let me to push your thumb down. Intact median nerve. So intact nerves in the hand. After that, the function, okay, and so on. So here, I will check function of your hands. Verbalize to the examiner what you are doing. Okay, so 3 tests for function. I will test your tendons. Okay, so can you do like that? I will hold your finger. Can you bend that? Can you do that? So flexor digitorum profundus intact. Can you do like that? Don't let me. Can you bend your finger? Yeah, you cannot. So the patient has flexor digitorum superficialis injury. So already you ask the patient about immunization from the start. Is your immunization up to date regarding tetanus? Yes or no? So according to his immunization, according to the wound, so the wound in the farm different than the wound in the kitchen. Clean or not, okay? So the patient needs antibiotic or not. The patient needs tetanus prophylaxis or not, okay? It depends from, it's different from station to station, different from candidate to candidate in the same circuit. The examiner can make for you a clean one. For another candidate, it's a high risk prone one. Okay, so don't be scripted. People for yesterday exam different than people from today. Okay. Next one, who want to practice?
Sorry, Dr. Hani, in the sorry, in this patient, what we seeing in this station, I mean, this wound, don't we have to check the sensations? I mean, digital nerves on the sides of the middle finger.
Yes, we check already. You mean sensation?
Yeah.
Yeah, he finished. The Dr. Tariq did that already. So you have to check the sensation in the C6 in the thumb and the little finger in the C8, okay, And middle finger, in the dorsum of middle finger, it will be C7, right?
Yeah. I mean, in case they, sorry, in case they made this wound in front of not say just an example, say if they made this mark in front of the ring finger instead, yeah, so we have to check the digital sensations on that particular finger as well, isn't it?
Yeah, what I need from you for the purpose of the station, check sensation in the thumb, little finger, and the middle finger. So radial, we are talking about median, sorry, radial and ulnar.
Yeah.
Okay.
Hani, I think so. He wants to say that distal to the wound.
Yes,
we should
exactly.
check
Yeah.
the sensation for that particular finger. That might be along with the tendon. The nerve is also involved. Nerve is also cut or no?
Yes, here you will check sensation on the dorsum, not on the palmar. Okay.
Yeah.
In the dorsum, it's not affected by palmar. Did you get my point?
But the sorry, but the wound is on the palmar side, isn't it?
The wound in the palmar side, and you will check sensation on the dorsal side of the, the middle finger.
Yeah.
Did you get my point?
Yeah.
It will be intact.
Clarify.
Yeah. Okay.
What is that along with the tendon might be the nerves, the digital nerves.
Yeah.
That particular fingers also cut, or you want to say
No,
like?
no, it's away. It's away. It will not be cut. It's away. It's the wound is palmar. The wound here, it's away from digital innervation. I got your point. I got your point. For the purpose of the exam, the motor and the sensory will be intact. Okay.
Yeah.
So
okay. Yeah.
don't let me to push down. He has good resistance in both sides. Here, good resistance. He has good resistance here also. Okay.
Right. Okay. Yeah.
So even he has good resistance. This one for median, right?
Yeah.
If he has good resistance in median, in power, in motor, and he has loss of sensation in median, for example, I will agree with you for this point. For example, if he has loss of sensation here, it will be for medial nerve itself or for digital innervation. So the median nerve is intact, right? Okay. So anyway, for the purpose of the station, it will not be like that. Don't worry.
Yeah. Okay.
You will find the motor and the sensory intact. Okay.
Yeah, that's fine.
Yeah. Okay. Next one, who want to practice next station?
I can try, Dr. Hani, if no one.
Okay, Dr. Ahmed Al-Amin.
Hello, Dr. Hani, can you hear me?
Yeah, Dr. Amin.
Regarding the C-spine clearance, according to the Canadian C-spine rule, if we don't find any of the high-risk factors, and we proceed to the one of the question we will ask from the low-risk factors, if they are also negative, and patient is already having the C-spine collar. So my question here, exact question is that for the rotation, to check rotation right to left, do we have to remove the collar, what you say, before doing the rotation? Because what I understand, with the collar in
just
place,
to open, I got your point. Just to open the front of the collar, okay? And you just pretend in front of the examiner that you are supporting the head and neck. Just a gentle support, okay?
Thank you.
So, just verbalize, I will open the front of the neck, okay, the collar, and try to move your neck to the left and the right 45 degrees. And just put your hands beside the neck. Just pretend that you are caring about the patient. Clear?
Very thank you, Dr.
Yeah. Okay.
Okay, can I start, Dr. Hani?
Yeah.
Okay, I'm going to wash my hand, put on my PPE. Hello, I'm Dr. Ahmed Al-Amin, ED registrar. May I confirm your name and age, please?
Salman, 47.
Nice to meet you, Mr. Salman. I have been informed that you fell yesterday from stairs and you're having a problem and pain in your hip. Is this correct?
Yeah,
I'm so sorry to hear that. Would you like me to offer you any pain medications right now?
it's okay.
Okay, so I've been informed to take some data from you and also do an examination, which will involve you have a look, feel, and do some movement and special tests for you. Would that be okay with you?
Yeah, yeah.
Mr. Salman, do you mind if a nurse will be attending with us the examination?
Okay.
Okay, so first of all, I'm going to check the vital signs for the patient. Mr. Salman, do you have any allergies, any medications you're taking?
No, no.
Any medical problems before, any surgeries
No.
done? When
No,
was
no.
your last meal and your last drink?
I cannot remember.
Can you tell me quickly about what happened to you yesterday?
Yeah, I fell from stairs and it was 2 stairs. I have pain in my both sides of head.
Oh, I'm so sorry to hear that. Okay, so let us now proceed for the examination. First of all, can you please, are you able to stand up on your own?
Yeah.
Okay, first of all, I'm going to go for inspection, general inspection for any asymmetry, any deformity, any abnormal movement, any muscle wasting. Then I'm going to go for a more closer observation for the patient. Can you take off your pants and stay just with your underwear? So I'm going to check for the hips for any swelling from the front, for any swellings, for any redness, for the presence of alignment of the hip joint. I'm going to also look from the side for the arches of the foot, for any flexion deformity, for any wasting of the muscles. I'm going to look from the back for the alignment of the hip joint, for any scoliosis in the back, for any wasting of the gluteus muscle. Okay, now, Mr. Salman, I would like you to walk. Can you walk? I will be standing by your side in order to support you in anything. Can you walk to the end of the room and come back, please? Okay, I'm going to watch for the
patient
gait.
has antalgic gait.
Okay, so antalgic gait. Okay, please, Mr. Salman, I need you to lie down on the bed. Now I'm going to feel for your joint, to feel the temperature of your joint. Okay, so I'm going to feel the temperature to check for the presence of any arthritis. Now I would like to do pressure over your joint to check for any bursitis or tenderness. I'm going to do pressure for the hip joint. Okay, now, Mr. Salman, I would like you to do, are you feeling comfortable? I would like you to do some movement for me, then I'm going to do the movement myself, okay? So I need you to bring your knee up as far as you can toward your chest. Yes, excellent. And then you can straighten it back to normal. Okay, thank you very much. Now I'm going to do the test for you. Okay, I'm going to hold from the ankle of the patient. I'm going to bend the knee to maximum, flexing the hip joint. Then I'm going to do extension. And again, I'm going to do for a flexion. I'm going to move to make an internal rotation and external rotation. Now I'm going to do bring the leg inside to make abduction and bring it outside to make an abduction. Okay, I'm going to repeat this on the other side. Are you comfortable, Mr. Salman?
Yeah.
Okay, can you turn back in the bed, please? I'm going to raise your leg up, and I'm going to go for an extension of the hip. Okay, thank you, Mr. Salman. Can you turn down? Can you turn back again? Okay, Mr. Salman, I would like now to do some tests for you. Okay, I'm going to put my hand below your back. Okay, I'm going to put my hand to make sure the lumbar vertebrae are straightened. And then I would like you to flex your hip joint. Okay, I need you to bend your knee and bring it up as far as you can. I will look for any flexion deformity. Okay, I'm going to repeat this on the other side. Okay, thank you very much.
Okay,
Now
the patient you are talking about which test?
Yes, the Thomas test.
Okay, the
putting
patient,
my hand below.
Yeah, he has here the affected side in the right side. Okay, so show us how to do this test.
The affected side is the right side. Okay, so yeah. Mr. Salman, I'm going to put my hand below the back. I want you to flex back your left side to bring your knee up as far as you can. I will, if there is pathology of the affected side, I will see the right side also being raised or getting flexed with the other side.
Okay.
Okay. Now I want you to do another test. I want you to stand up. I'm going to support your sides, and I need you to stand one at a time at one of your feet. So if the patient is having a problem, when he is standing on the affected side, the hip will fall down on the other side because of the weakness of the abductors of the hip. Okay, so thank you, Mr. Salman. We have completed the examination. Let me help you now to dress. Okay, I have been informed there is an X-ray for you. I need to check this X-ray, please. There is an X-ray. Okay, so Mr. Salman, according to the examination and the X-ray, you're having a fracture in the part of your pelvis, the anterior part, we call it the ramus. For this, I need to keep you in the observation room, and I'm going to do a full examination of your lower limbs, the nerves, as well as the other bones of the lower limbs. And also, I'm going to consult the nerves and the vessels of the lower limbs. I'm going to run some tests for you. I'm also going to consult an orthopedic doctor for further management. Right now, I need you to lie down. I will apply a binder over your pelvis in order to prevent any movement or any injury to internal structure. Would that be okay for you?
Okay, thank you, Dr. Ahmed.
Do you have any question? Thank you very much. I wash my hand, take off my PPE.
What do you think, guys? What do you think, guys?
Excellent approach, and he didn't miss any step.
Okay.
What do you think, Dr. Hani?
I think it's amazing, mashallah. Okay, you are controlling your tone, you are controlling your communication with the patient, verbalizing everything to the examiner. From my side, if I will give you 10 out of 10. Here is the most important to verbalize to the examiner and also give instruction, clear instruction, and simple instructions to the actor. So please expose the upper and the lower part of your body. Only wear your underwear, or you can say boxer. So here I will inspect from in front for blah, 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 from side, from behind. You can rotate behind the patient, or you can ask the patient, can you turn 90 degrees? Can you turn 90 degrees? It's up to you. After that, can you walk for me? I will check for gait. The patient will walk with antalgic gait. So verbalize to the examiner, the patient has antalgic gait. Okay. After that, ask the patient to lie down. I don't remember. Did you check the measurement, Dr. Ahmed?
No, I forget this one.
Yeah, it's very important.
Yes.
Yeah. So can you lie down? So here, and start by inspection, palpation. Inspection here, you did already for inspection. After that, palpation, it means you will check for temperature, and also you will check for tenderness, looking at the eyes of the patient. After you finish that, measurement. So measurement, it will be for apparent and for true leg. So for apparent, it will be from umbilicus to the tip of medial malleolus, and the true leg, it will be anterior superior spine to medial malleolus. So just to verbalize, you don't have measurement in the station, in the exam. Just to verbalize one hand on the umbilicus and one hand on the medial malleolus. After that, one hand on the anterior superior spine and one hand on the medial malleolus. So the right hand on the medial malleolus, don't remove. It will save time. So one hand on the medial malleolus and the other hand on the umbilicus. After that, both on the anterior superior spine. Apparent, true, to save time, like that. So after that, you can do active movement. I think it's clear for you guys regarding active movement. After that, you can ask him to lie on his tummy, and you will do passive hip extension. So this test, as Dr. Ahmed did, here you can do on both sides. Don't do in one side, Dr. Ahmed, okay?
Yes, Dr.
Yeah.
Yes.
Yeah.
But because you told me that the problem was on the right side, so
yeah.
Should be
in the start. In the start, yes. I said I have pain on my both sides of hip. So how to understand he has problem in the right side or in the left side? So you will put left hand behind the lower back, and you will do passive or active flexion.
No, it should be passive flexion.
Yes, passive. So you will start by passive for the right side. Okay, so one hand here, one hand will do flexion of the right side. If you find the left side raising, so it's a positive. After that, you will repeat in the other side. You will one hand here and you will do flexion of the left side. If you find the right side raised, so it's a positive also. So if positive only in one side, he has problem in one side. If he has positive test in both sides, so he has positive in both sides. I think it's clear. Okay. So the normal, you will do flexion for one leg, the other leg will not raise. This is the normal. The abnormal, the other leg will do raise. Okay. After that, Trendelenburg position, you will be sitting or even standing, no worry. Sometimes some people in the previous exams, they did not find any bed. Okay. So how we will do examination, guys, for the patient?
Sit in front of the patient.
Yeah, but how we will do lying? No bed.
On the floor.
On the floor. It's their problem, right? Their problem. Okay. How we will do that? Otherwise, there is two chairs, right? Two chairs. So you can put two chairs in front. So I prefer it will be on the floor if you don't find. But anyway, in the UK, it will be not like that. Anyway, so Trendelenburg position, if he has any tilt, it will be positive. So if the one raised, the pelvis is raised, it's a normal. But if the pelvis is lowered, it means it's abnormal. Thank you, Dr. Ahmed. Well done. Okay.
Thank you.
So this patient needs binder, embolization, don't move the patient, and you can refer now. Okay. So next station, who is happy to do next station, guys? The last station. Yeah.
Only one question, sorry. This was the feedback from the candidates who appeared in the November in UK.
Yeah.
That there was the station of the hip examination as well as the back examination. And the question regarding the hip, once the candidate has finished the examination,
yeah,
the actor has asked, okay, what I have, and I am like, I'm a what you say, dancer. When I can resume my work back to like dancing floor. So these kind of question, if the actor is asking, so is there any global answer or any statement we can?
Any X-ray? Any X-ray in the station?
I didn't heard about X-ray. The candidates told that there was no
yeah,
X-ray.
You cannot give a clear answer without X-ray, without positive test in the station, right? So
yeah, that's what
if Thomas test and the Trendelenburg test are negative and the patient is walking, so X-ray normal, so no need for any intervention. But if the patient has a positive test, whatever this test or this test, and he has X-ray fracture, it depends on the fracture also. So if the fracture bilateral, this one needs OR. Okay. So this unstable. Okay. So it depends on the fracture. It depends on the finding in the station, right?
Yeah, I agree.
Yeah.
I think, Dr. Hani, we can transfer this also to the orthopedics. Like we say, it is too early to give an opinion right now. For example, it will depend upon the improvement and the follow-up and the opinion of the orthopedic doctor, for example, if he will be referred to orthopedics. Like
Yeah,
try to escape from such a question.
Physiotherapy,
yeah.
we can also.
But
yes,
the
yes,
most important you have to ask about X-ray, but don't ask about X-ray. You can verbalize to the patient according to your examination, most likely problem you have suspected fracture in your pelvis or on your hip. Okay, so I need to do X-ray. You have trauma and you have a positive test. So I need to do X-ray. At that time, they will show you the X-ray. Okay. If you want to ask it directly, if you want to ask directly the examiner any X-ray, so he will show you the X-ray. But I prefer to explain what is the indication for X-ray. It will be better.
I think it's a unilateral superior inferior pubic rami fracture, sir.
No, it's open book, bilateral.
No,
this one not open book. This one not open book. Open book, it means the distance between symphysis pubis, it's more than 5 millimeters. Okay, so
no,
this one
last
is bilateral
exam I'm saying. In last exam, they showed unilateral superior inferior pubic rami fracture.
Yeah, you mean this image, but only unilateral.
Yes, sir. Yes, sir. I mean.
So at the moment, you can give the patient explanation. This one, I will refer you now to orthopedic team. They will decide if you they will do open reduction and internal fixation. They will give you time to stay at home, and they will give you the exact time to start dancing, as you see. Okay.
Even Dr. Hani, I'm sorry for the input, okay? With the hand wound.
Yeah.
The experts, she asked the question at the end. I am a guitarist, so when I can resume playing the guitar?
Yeah. Here regarding the exact time, you can give the answer to the plastic surgery. Okay. So hand wound, and you will refer to plastic surgery or hand surgeon. It's up to you, but I prefer hand surgeon. Okay. So they will give you clear answer for that. No worries if you will tell him about the other specialty. Okay.
Thank you, Dr. Hani.
Yeah. Okay. Next station, the last station, who is happy to practice?
I can if there's no one.
Yeah, Dr. Aziz, thank you. The last station. And very, very important station. Okay, you can start if you are happy.
Okay, just a minute.
Okay, you have 30 seconds to prepare yourself.
Okay, I can start.
Yeah.
I need to wash my hands and wear PPE. Good morning, I am Aziz, ED registrar. May I know your name and age, please?
Yeah, Hilal, 42.
Nice to meet you, Ms. Hilal. I've been asked to take some data from you and examine you as well. Would it be okay with you?
Yeah, sure.
Do you have any pain now? Are you comfortable now?
Yeah, I am comfortable.
Okay, so how can I help you today?
Yeah, I have been in my right knee. I was playing football last night, and I have severe pain after that. I took painkiller now.
I'm sorry for that. I need to check vital signs. Do you have any medical disease?
No.
Are you on any medication?
No.
No. Did you have any surgery before?
No.
No. Okay. I need to examine your knees and this involve me look, feel, move, and do some special tests. And exposure of your legs would be okay with you?
Okay.
Okay. Now, can you stand in front of me? I will do a look for asymmetry, deformity, swelling, scars, involuntary movement, fasciculations, and tremor. After that, I will inspect closely from the anterior, lateral, and posterior side for quadriceps, varus valgus deformity, extension flexion abnormality, and muscle wasting. Now, can you walk to the end of the room and come back for me? Now I will assess for speed, symmetry, balance, and tandem gait, heel walking. Thank you. Now, can you lay down for me? I will assess your knees. I will palpate bilateral knees for temperature for the arthritis. Now I will palpate the knee for quadriceps tendon and patellar tendon, and from the medial and lateral side of the knee. After that, now I will check for the effusion. With my one hand, I will push from the suprapatellar area, and with the other hand, press downward. If it's positive, it means there's large effusion. Is there effusion? Is it positive? If it is not positive, I can do the sweep test for the small effusion. With my one hand, I will sweep from the medial side, from down to the knee, and from the other side, from up to the knee. If there's a fluid, it will be positive. Now, thank you. Can you flex your knee for me? Now I will palpate the patellar ligament. Maybe there can be tendonitis, and medullary and lateral side of the patella. After that, I will palpate for the tibial tuberosity and the fibular head. Now I will palpate for the popliteal fossa, and after that I will measure for the quadriceps bulk. And thank you. Now we will do a few movements. Can you flex your knee? Can you move your heel to your bottom? Thank you. Now you can extend again. Now just relax. I will do the same for you. I will do the flexion, knee extension, and hyperextension. Thank you. Now we have some special tests. Firstly, I will do anterior drawer test. Just relax and bend your knee. I will pull the tibia for the anterior cruciate ligament. After that, I will push at the same position for posterior cruciate ligament. After that, I will check lateral medial ligament. With my one hand, I will support tibia, and with the other hand, at the medial side of the thigh, I will push outside for the lateral ligament, and my hand at the tibia will be same, and I will push inside from the lateral side of the thigh to check medial ligament, and after that I will do McMurray test. Now just relax. I will give your knee position. With my hand, I will support the knee, and with the other one, I will do medial rotation and extension. And after that, medial and lateral rotation and extension for each side. And lastly, I will displace the patella laterally. And thank you. Now I have finished my examination. Is there any positive sign, examiner?
Thank you. Okay. What is the diagnosis, Dr. Aziz?
I think it's a long station, so I don't know which one is positive.
But for sure, you will not get diagnosed. Okay. What is the diagnosis, guys, and what is your comment regarding this point?
It's a normal examination. Usually could be just a sprain or something like
How you know normal examination?
the examiner didn't comment on any test.
Yes, because Dr. Aziz did
Because
not
I
ask
didn't
the
ask.
patient, if you have pain, tell me. And I will look at the eyes of the patient for any tenderness, right? Okay.
Okay.
So you have to check for tenderness. Okay. So this is your point, Dr. Aziz. You did everything, but for the examiner, he understands that you did everything, but he cannot do he cannot give you more than 6 marks, right? Okay. So yeah, the examiner want to give all people 10 marks. Be sure of that. But give him a chance. He want to give you, but he want to take in evidence. Okay. So here, can you stand for me? Expose your upper and the lower part of your body, except underwear or except the boxer. Okay. So here I will check from in front for blah 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 blah. I want you to mention by name quadriceps. I want you to mention by name any knee swelling or deformity, foot deformity from side by name, knee flexion, foot arches, toe deformity. From back, I will check for iliac crest alignment, gluteal muscle bulk, popliteal swelling, hand foot abnormalities. This is how to study, guys. I can ask you to watch videos all over the world. You have more than million videos for examination, but I am giving you how to get 10 out of 10. Okay, how to focus on the most important points. So can you stand? I will check from in front for blah 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 blah, from side blah 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 blah, quickly from back blah 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 blah. Thank you. After you finish everything, thank you. After that, can you walk for me? And try to support the patient. Maybe he cannot walk. Okay. So if you find antalgic gait, you can mention the patient has antalgic gait. Okay. Can you lie down on the couch or on the bed? So I will feel. An inspection done already. The patient was standing. So now feel. The next step is feel. So I will feel for temperature, for any inflammation, for any septic arthritis. After that, you can palpate the knee. Palpate the knee with leg straight. Okay. So after that, you will do test for effusion. After that, palpate while the knee is flexed. Clear, guys? You have 3 steps. Number 1, palpate in extension. After that, test for effusion. After that, knee flexion. Extension, effusion, flexion. Very easy. Okay. So you will palpate the knee for what? Quadriceps tendon. So here you will, how you know the patient has quadriceps tendon problem, rupture or anything? I don't want you to just to do the exam. I want to get benefit from this test. Okay. Palpation here, how you know the patient has tenderness?
Because the patient face
facial expression.
Facial expression. So you have to verbalize to the patient, to the examiner. I will palpate your knee while you are extending your knee. Verbalize to the examiner like that. I will check for tenderness, looking at the patient eyes. So quadriceps tendon and your eyes on his eyes. Clear, Dr. Aziz?
Yes, Dr.
Here in the exam, if you find the patient has tenderness in this point, he has quadriceps tendon rupture. Okay, you will support that in next test. Okay, so if the patient he make his eyes like that, he show discomfort, it means he has problem here. At any time you feel his eyes with discomfort, you will diagnose. Okay, so quadriceps tendon, no eye expression, no discomfort. After that, the patella. What do you need from patella? medial, and the lateral border. If he has no discomfort here, Dr. Aziz, and no discomfort here, any fracture in the patella?
No.
If he has no discomfort in eyes when you touch the medial border of patella, and no discomfort when you are touching the lateral border of patella, do you think he has patella dislocation?
No.
Clear? Okay, so you will understand everything from the start. When you are doing palpation for quadriceps tendon, palpation for patella medial and lateral border, it means you excluded patellar rupture, tendon rupture, and you excluded dislocation. If he has discomfort in medial and the lateral border, okay, so maybe fracture, maybe dislocation, okay, in the patella. After that, you will do effusion. So number one, patellar tab. Verbalize to the examiner, I will check for joint effusion. Okay, the same extension. Now you did not do flexion at all. So just hold the one hand like that. Okay, after that, by one finger, up and down, done. I will do patellar tab for large effusion. Done. Don't waste the time. Thank you. Next, I will do a sweep test for a small effusion. So one hand from the other side from up to down, and the other hand from down to up. Okay, so the left hand up to down, right hand down to up. Done. No need to explain more. Okay, after that, can you bend your knee? I will do palpation. So palpation in extension, after that effusion, after that palpation in flexion. Okay, so here you will palpate the knee for what? Patella tendon, and check for tenderness in facial expression. After that, tibial tuberosity. After that, medial joint line. You will check the medial joint again. Okay, so medial joint and the lateral joint. Okay, after that, you will check also for head of fibula. Head of fibula, you will check for if the patient flexed or extended.
Flexed.
Flexed. Okay. So if you are touching the head of fibula lateral or medial?
Lateral.
By thumb of your hand. So if the patient has discomfort, you are looking at his eyes and he has discomfort, what does it mean?
Common peroneal nerve damage.
No,
this station,
guys, this station is for knee joint, not neurological exam. Okay, so you are expecting fracture or dislocation or tendon rupture, right?
Yes.
Okay, so the most important here, palpation. Palpation is the key of passing this station. Okay, you have 3 points. Okay, so first of all, palpation here. If the patient has high temperature, what does it mean?
Septic arthritis.
Septic arthritis. Done. Palpation important here. And after that, palpation for quadriceps tendon, for patella, medial and lateral borders, and the patella tendon. 1, 2, 3, 4. 4 borders. Up and down tendons. Medial and lateral borders. Done. Okay. It will show you quadriceps tendon rupture. It will show you patellar tendon rupture. It will show you patella fracture or dislocation. After that, effusion. It will show you if the patient has effusion or not. After that, flexion. You will understand if the patient has rupture also, again, whatever quadriceps or patella. Also, it will show you medial and the lateral border of the patella for patella fracture and dislocation. After that, here you can add patella but fibula head. If the patient has fibula head tenderness, what does it mean?
Maybe fibular fracture.
Maybe fracture.
Fibula head fracture. So if you are doing palpation is the key of this station. If the patient has discomfort, you are looking at his eyes and you are touching the fibula head here, and he has discomfort, what will you do? What will you say to the examiner?
Apologize to the patient first and say that there is a
Excellent.
possibility of fracture.
I'm sorry, do you need painkiller? The patient has discomfort, the patient has tenderness. While palpating the fibula head, most likely fibula head fracture. Clear, guys?
Yes.
This is how to catch the station. Maybe you will finish all the station, but you don't know what is the diagnosis because you did not use your approach. Okay? Maybe you will watch this video all over the world in YouTube, here, but you don't know how to get the marks. Okay? So here, after you finish fibula, you can go for collateral ligaments. If the patient has a tenderness in the medial line and the lateral line, so maybe he has collateral ligaments problem also. Okay. After that, popliteal. This is how to check popliteal fossa. So the last step in flexion. So you will check for popliteal fossa for any swelling. After that, you will measure. You will measure the quadriceps circumference. It will be 20 centimeter above tibial tuberosity. From tibial tuberosity, 20 centimeter. And don't waste time. Just verbalize to the examiner. I will check. You don't have measure, so just verbalize. I will check I will measure the circumference of quadriceps 20 centimeter above the quadriceps, tibia tuberosity. Thank you. Okay. So after that, tendons. You have here the last step, special test. So anterior drawer test, same as ligament test. No need to do both of them for what, guys? Which tendon?
Anterior cruciate ligament.
So, yes, no need. Okay. The examiner, he understands that you did anterior drawer test. So you can verbalize to the examiner, no need for ligament test because the same as drawer test, anterior drawer test. Done. Okay. So here how to catch the diagnosis here. So you will do the test and verbalize to the examiner, I will compare laxity in the other leg and ask the patient, if you have any pain, tell me. Okay. And I will look for tenderness at the eyes of the patient. So you have 3 points. You will compare with the other side. Number 2, discomfort. Number 3, ask the patient directly if you have any pain. Okay. So if you find discomfort in the eyes of the patient, it means what?
Anterior cruciate ligament injury.
Anterior drawer test positive, and you can say it's anterior cruciate ligament injury. After that, posterior, it will be the same, but this one you will pull up, this one you will push down. Okay, done. Okay, and check also for discomfort. After that, McMurro's. So here, this test for the meniscus. Okay, so you can do flexion and a rotation. How to do that? Support the knee by one hand and do rotation by the other hand through the ankle. Okay, so you can do medial rotation. Medial rotation, it will be which meniscus, medial or lateral? The opposite.
Lateral.
The opposite. It will be for lateral. Okay, so verbalize quickly. Can you bend your knee? I will do medial rotation. If you have any pain, and I will check for discomfort in the eyes of the patient. So if the patient has discomfort in this test, you are doing medial rotation. What does it mean?
Lateral meniscus.
Tear, lateral meniscus.
Lateral meniscus tear, okay, or injury. Okay, so it's macronoris positive. If you will do lateral rotation and the patient has discomfort, what does it mean?
Medial
meniscus injury.
Yes, I think it's clear now. Okay.
Yes, doctor.
Yeah. So the key of station, check the tenderness, check the discomfort in the eyes of the patient. Okay. The actor is instructed to do discomfort in only one test. He will do facial expression in only one test. Clear? Okay. So here how to do, support the knee by one hand and do rotation in the ankle by one hand, and after do rotation, do extension. So flexion, rotation, extension. Flexion, rotation, extension. If he has pain after that, it means it's positive. Okay. And regarding the test for which test for lateral and medial collateral, guys?
Valgus and virus
Valgus and virus.
Yes, so you will do stress on the lateral side and the medial side. If the patient has stress on the lateral side and he has pain, what does it mean?
Lateral collateral ligament injury.
Medial collateral.
Yes.
If the pressure from the lateral side, then it is a medial collateral.
If you do pressure here, so you are separating. Unfortunately, I don't have this slide. Okay. So if you are doing separation in lateral, it means it's a lateral collateral ligament injury. Okay. If you are doing separation from medial, it means the medial collateral ligament injury. Okay. The most important, you are separating the tibia from the side. If you are separating through the medial side, it's medial collateral ligament injury. If you are separating from the lateral side, it means lateral collateral ligament injury. Okay. So we finished today session. Okay. Thank you, guys. Anyone has any question before we stop?
I have two questions.
Yeah.
First, in drowning hypothermia station.
Okay.
We know that up to temperature 30, we can only give 3 shocks. My question is, from 30 to 35 centigrade temperature, if the patient is still in the shockable rhythm, do we double the duration of the shock as well, along with the medications, or we will follow
No, they did not mention that. They said double interval of medicines, cardiac drugs. Cardiac drugs here, it means adrenaline and amiodarone.
But what about the shocks?
The shocks, they said clearly, if refractory and the temperature is less than 30, withhold. If the temperature is more than 30, you can give shock, no problem. But it will be every 2 minutes.
Every 2 minutes, okay.
They said double interval, the cardiac drugs. They did not mention shocks.
Okay, second question, Dr. Hani. If we have in the ATLS a chest wound, which is either sucking or like a non-sucking wound. So when we approach the patient in the B, when we are exposing.
Okay.
So whether we have to put the dressing immediately first in the B, because we have exposed the chest already and we have a visual clue that there is a wound. So dressing first, or we should continue the content of the B, like for the apply monitor and trachea central neck veins checking. What shall we do first? Dressing?
Okay. For the purpose of the exam, you will find wound in the mannequin, and your point now, you will care about the wound, or you will connect monitors. Expose the chest connector monitors. This is your point.
Yeah, I mean, connecting monitor is not a problem. I believe that we can do it along with that. We need to proceed for examination first, or to address the dressing of the wound first.
Don't care about the wound. the wound here, it will be after assessment. So what is the priority, assessment or intervention?
Assessment.
Assessment
first.
Assessment first. So don't start any intervention until you finish all assessment in the system. So don't give high flow oxygen. High flow oxygen here, it's intervention or assessment? Intervention. So finish all airway assessment. So what about airway? Patent? Okay, so I finished my assessment. Give oxygen. Okay, so intervention. If the airway is not patent, I will continue assessment because I did not finish assessment. So why not patent? I will ask any large tongue or largest lips if the station is anaphylaxis. So I will go step by step. So now your point in breathing and your point is the patient, whatever open pneumothorax or not, because there is wound in the chest. So I will go for assessment. Assessment here, I will not do any intervention. Intervention means dressing. Intervention means three-sided occlusive or four-sided occlusive dressing, okay, or adhesive dressing. So the intervention here, it means also chest drain. No, I will not start any intervention until I finish all assessment. So what about oxygen saturation? What about RR? What about trachea? What about neck veins? What about inspection? Now I am in inspection. You can verbalize to the examiner. Don't ask him, what about inspection? You can verbalize to him, I can see wound in the chest, in the right and the left side. Be professional. So ask him exactly, where is the wound? Which intercostal space? Because it's not clear in the mannequin. So you have to ask him clearly. After that, go for palpation. What about palpation? What about chest expansion? What about percussion? Okay. What about auscultation? What about air entry? So after that, you will take clear idea. If he said, for example, the trachea is central, so it's not sucking wound for sure. If he said neck veins are normal, if he said no regarding air entry is normal, so maybe superficial wound. So you have to ask in inspection. Don't go for intervention yet. You have to ask him clearly. What about the wound? Is the wound sucking or not? After you finish all inspection, palpation, percussion, auscultation, you can do dressing, Dr. Amin. Is that clear for you?
Yes, doctor.
And
Yeah.
Dr. Ani?
Yeah.
Need cervical collar?
Of course, from the start.
Stab wound with the knife or anything like this at home.
Any trauma, you don't know where is the problem yet. So start with cervical spine, manual inline stabilization, and after that, talk to the patient if he's airway patent or not. If airway patent, high flow oxygen and the cervical cord.
Okay.
Yeah.
Thank you.
Okay. Welcome.
Thank you.
Any other question?
Last question.
Yeah.
Sorry. Can I complete the question regarding to the previous question of Dr. Tariq? That can we, when we are manually stabilizing the spine, and same time when we are stabilizing while the nurse or my colleague is preparing for a cervical collar sizing, we can start the assessment of airway or no need? First, we completely fix the cervical collar, then we go to the A.
Don't put the cervical collar. Cervical collar is intervention, right?
Exactly.
So any intervention after the assessment. So you finish assessment. The last point in assessment, the airway is patent.
It's not clear, Doctor.
So I think also if you applied cervical collar, if the patient needs intubation, you cannot intubate while the collar in place.
Yes. Cervical collar is intervention, and any intervention after finishing assessment. So I will do manual inline stabilization. I will ask the examiner, is the patient talking? Yes. Is the airway patent? Yes. So high flow oxygen and the cervical collar, done. Clear?
Sorry.
Clear, guys?
Yeah.
Yes, Dr. Hani.
Okay, I will do the opposite. It will be not patent now. What I will do, I will escalate to intubation. And after that, cervical collar. Listen to me. So I will be behind the patient, manual inline stabilization. Is the patient talking? No. Is the airway beating? No. Okay, I will do any, because the station of ATLS. So my concern now, foreign bodies and bleeding and the vomiting. I will not talk about large tongue or large lip. Okay, so not logic. It's not station of anaphylaxis. So I will ask the questions relevant to the station. So trauma. So any bleeding, any foreign bodies, any vomiting inside the mouth? Yes. Can you do suction? Yes. Is the airway patent now? No. Can you apply oropharyngeal airway? Is the patient tolerating oropharyngeal airway? Yes. So the patient needs intubation because tolerating oropharyngeal airway. Am I competent in intubation? No. Is the anesthetist available? Yes. Intubation done. Can you connect it to back valve mask? Can you give rate for ventilation? One ventilation every 5 to 6 seconds. What about oxygen saturation now? I have to confirm a tube is in. I am not in breathing. I am still in airway. What about oxygen saturation now? What about EtCO2? Normal? So the tube is in. Okay. So apply cervical cord. Clear, guys?
While
Yeah,
intubating
clear.
and while doing any procedure like airway suctioning, we have to still keep our hands on the side of the both side of the head,
Yes,
and we
yes.
are stabilizing the head.
Here, for the purpose of the station, for the purpose of the time, they will not talk about you will hand over the head and neck to the nurse. You don't have time to mention everything. So now I will intubate. I am holding the head and the neck. Can you please, nurse A, can you please hold the head and the neck while I will intubate? Yeah, this ideal, but you don't have time to mention everything. Clear?
Thank you.
Yeah. Okay. Another question?
Yeah, yes. I'm asking what is the reason behind asking the patient about the allergy and last time he eat or drink in case of doing examination?
No need, no need. Here, if you will ask the patient allergy because he will give painkiller, just it, okay?
Okay.
Yeah, and last eat and drink is just ample history. So if you will ask the patient any trauma, any past medical disease, any surgery, just ample history quickly, it will give you a clear idea if the patient has trauma or surgery or anything. But if you want to proceed directly to the examination, no need.
And also, Dr. Hani, last eat and drink, sometimes it is asked if the patient will need surgery, so you will inform
yes,
the
any intervention.
Yes.
Okay, but for the purpose of the time, if you want to skip this point onwards. Okay, guys, thank you and bye.
Okay, thank you, Dr. Hani. Thank you.
Thank you, Dr. Hani.
Welcome, bye.
Thank you.
Thanks, Dr.
Thank you, doctor. Thank you very much. Inshallah, tomorrow it will be system examination. Don't forget, and please prepare well for that.
About what time?
It will be the same, 6 to 8, 6 to 9 p.m. KSA, and 3 to 5 or 3 to 6 UK time.
Unfortunately, we'll miss it. Okay, thank you. We'll see the recording.
Okay.
Okay, thank you.
Okay. Bye-bye.
Bye-bye.